we're live.
Bonadar, croeso I gyfarfod bod iechyd prifysgol Cymtaf Morgannwg, Hofyn arresting croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the bi-monthly meeting of the Cymtaf Morgannwg University Health Board, which is being held in public. We are, as usual, broadcasting this meeting live, so a very warm welcome to those who are observing the meeting in person and also virtually today. As always, a copy of the video of the meeting will be available following this meeting on our website for those who wish to view it. Just a couple of practical points before I do some introductions. As usual, if I can ask those presenting their reports to take account of the fact that members will have read them, and if you can just highlight the main points in the paper and draw attention to anything that might have changed since it was drafted, because as we work in a fast-moving environment and things move very, very quickly following the publication of our papers. Just looking to take a short break around 11:30, just to make you aware of that. In welcoming guests to the board this morning, I'm delighted that we have one member of staff, Jonathan Arthur, Head of Audiology, who's with us this morning and observing the board in person. Very warm welcome to you, Jonathan. Also, warm welcome to Adam Cook-Young, who is here to present the listening and learning story relating to acute frailty and care of the older person and the patient hospital journey. So we're coming to you shortly, Adam, but very warm welcome to the board. Also a welcome to Matt Jenkins, our Regional Integration Director. Matt's here to present agenda item 5.4 in relation to the regional model of integrated community care services. And I have extended an invitation to Matt to attend future board meetings if he's able to. I think there's so much going on now, not just here within our own space, but in partnership with our health boards, our local authority colleagues and others, that having Matt's involvement and engagement in our work, I think will be really useful. So Matt, really good to see you this morning. Can I also welcome Kerry Bear and Elizabeth Stevenson from Clais Cymru, and also Helen Watkins, our Deputy Director of People, who is here on behalf of Howell Daniel, our Executive Director, and Helen will be joining us for this board and for the Remuneration Committee, which is meeting afterwards. I've been advised that both Linda and Patsy are online. I can see you both there this morning. Good morning, both. Nice to see you, and thanks for joining us via Teams. Apologies for absence. We've received apologies from Mel Jehu, one of our independent members, Lauren Edwards, Executive Director of Therapies and Health Sciences, Howell Daniel, our Exec Director for People, Philip Daniels, our Exec Director of Public Health, Lisa Curtis-Jones and Anne Morris, both Associate members. I don't think there are any other apologies this morning. Moving on to item 1.3, declarations of interest. I've not been notified of any, but if there's anything that requires declaring, please do so now. No? Okay, super. Right, moving on to item 2, the consent agenda. Just to point out that, as usual, we've given colleagues the opportunity to have matters from the consent agenda brought forward earlier in today's agenda if there are substantive items that need to be given further discussion. Can I just check to see if there are any issues that people wish to move to the main item of today's agenda, or they're happy for them to be left where they are? No? Okay, fantastic. Thank you very much. Okay, item 3, our shared listening and learning item. Really pleased to invite Adam Cook-Young to present today's listening and learning story. Just to say, I think there is a presentation that you've got. Just to advise those people who are watching the live stream this morning, you won't be able to see the presentation. And if colleagues can just give the technical team a few moments just to load the presentation, there may be a slight delay in putting it on screen. So Adam, I'll hand over to you, and if we just give it a moment until the presentation arrives. Thank you very much.
Do you want me to stand up?
It's entirely up to you, actually, whatever makes you feel comfortable. I'm not stepping over a particular rule, but yeah.
Let me know when you're ready for me to start. Always takes a minute.
There we go.
Okay. So sitting here, obviously there's an awful lot of names I didn't recognise, and I look at the name boards and I see an awful lot of important titles, but my purpose here is to talk to you about something that, or someone that is very, very important, and it's a representative of a patient we have in our health board here. I know some of you may have heard it before, but it was felt that the wider board should hear this patient's journey.
Yeah.
So I'm going to read it almost verbatim because there's an awful lot to get through and I don't want to miss anything. So good morning, my name's Adam. I'm a clinical practitioner based in the medical team at the Princess of Wales Hospital in Bridgend, and I specialise in acute frailty and care of the older person. I've been asked to share this journey with you. I have shared it twice before at the safety committee and the quality improvement. So next slide, please. I first wanted to start by sharing these images with you, so you may have seen them. They are powerful reminders that each one of our frail patients have had a whole life and are not just the vulnerable person that we see on our wards, but also educated, strong-willed and influential people. As this patient's journey is very much a timeline and discussions around bed days, I wanted to share these images to remind us that the story that follows represents a true lived experience of one of the patients within our health board. A story that is all too common for my patients. It's from last year, but it does remain very typical. Next slide, please. So for ease of glance and understanding, I've used black ink for clinical issues and green for social and blue for therapies. On February the 17th, the patient, who's an 80-year-old gentleman, was referred to secondary care by his GP with general decline and confusion. He was diagnosed initially with a lower respiratory tract infection that did not need any specific treatment. The next day, on February 18th, initial social needs were identified after discussion with the patient's only next of kin, which was his friend. It was reported that he was self-neglectful and was taken to his bed for some time before admission. The same day, he was seen by physio, but he couldn't engage because he was too unwell. He was later diagnosed and treated for an acute kidney injury. 4 days later, on February the 22nd, he had a joint physio and occupational therapy assessment. He was mobilising at his baseline, and all of his equipment was already at home from a previous admission. On day 6 of admission, the medical plan requested referral to social services for support of discharge, but he went on to develop a new oxygen requirement and was treated for his first hospital-associated infection. 6 days later, it improved, but had an ongoing oxygen requirement and subsequently was diagnosed with COVID-19. Next slide, please. A week later, on March 7th, he had another review by physiotherapy and again was fully able to mobilise with a Zimmer frame at his baseline function and again was discharged from therapies. By June 9th, he was discharge ready, which was on day 20 of his admission. On March 14th, social services confirmed receiving the referral for the patient and he was awaiting now a social worker to be allocated. Another 2 days later, the patient was found to be confused, but this was in keeping with his underlying long-term cognitive issues rather than an acute medical change, and he remained discharge ready, but subsequently was found to have a gut infection, which was treated with oral antibiotics and was not discharge dependent. After another 13 days, he was intermittently confused and we repeated his confusion screen. Later, he became unwell and he was treated for his second hospital-associated infection, pneumonia. The patient was discharge ready for 21 days before becoming unwell again. Our patients don't stay stable. Next slide, please. The patient was unwell between April 5th and April 19th, but after 14 days, he was discharge ready again. 2 days after his initial illness, he was allocated a social worker. Social services were unaware of the interim sickness period, which meant that he waited 38 days for a social worker to be allocated, and now he was waiting for them to assess him. A week later, on April the 28th, he was still waiting the assessment. On April 3rd, he was reassessed by physiotherapy and deemed to need to have maintenance physio to prevent deconditioning. He remained discharge ready. After about 2 more weeks, the patient was still waiting, so the ward manager sent an email to chase the social services. Another 3 weeks later of waiting, occupational therapy had chased social services and they stated that they were due to assess him this week. It took another 11 days for them to come and assess the patient on June 16th. The outcome was that the patient lacked capacity around discharge and we needed a best interest meeting to be arranged. After waiting 38 days for an allocated social worker, we waited a further 56 days for the social worker to come and see the patient. Next slide, please. After another 13-day wait on June 29th, the best interest meeting took place and the decision was made that the patient needed residential home placement. At this point, of 132 bed days, 107 were social, 94 of which were waiting for either an allocation of a social worker or for the social worker to come and visit the patient. And now the inevitable placement would start. Over the next few weeks, the patient had symptoms of long-term conditions which could have been managed well in primary care. However, he yet again became unwell. Next slide, please. On July the 4th, 5 days after the best interest meeting, the patient had rigors and was treated initially for sepsis of unknown origin. Later, we treated with targeted antibiotics for a likely biliary source. The patient had improved both clinically and biochemically, but ultimately, after an initial improvement and an illness period of 9 days, he continued to have his fourth decline. The patient's reserves were effectively spent and his condition declined. He stopped eating and drinking and became increasingly agitated. Efforts were made to encourage, but his swallow became unsafe and there were failed attempts at NG feeding. We had to move from cure to care. Next slide, please. So to summarise, the patient was discharge ready on day 20. Social services confirmed receiving the referral on day 25. After 21 days of being discharge ready, the patient had his first hospital-associated infection. Evidence shows us there's an increased risk of harm when a patient is in a hospital environment, and we can't escape the iatrogenic frailty that is caused by this environment. It's well evidenced that aside from infection, there is an increased risk of falls, restrictive practice, as generally patients are not free to get up and walk around and decondition by simple things like not being able to go and make their own drinks. This increases their levels of frailty, also known as harm. We are doing harm to our patients, not just physically, but these prolonged admissions take an emotional toll on them. I think about being on holiday in a place I want to be, but when I get home, I appreciate my own space, my own bed. To think about being in a place that is unfamiliar to me and in somebody else's control is somewhat unbearable. But we have to witness it every day, the longing, the waiting, the questions, the wait for discharge, and often watching patients simply giving up. All of this is unreported outside of length of stay. After another 38 days, on day 63, a social worker was finally allocated, and the patient was not seen. But the patient was not seen by the social worker for the 56 days on day 119. And finally, after more waiting on day 132, a discharge plan for residential was agreed, which meant another wait placement. Just 5 days later, he became unwell again and was treated for sepsis, but ultimately he would not be able to recover. And after an initial clinical response, the patient deteriorated further. We had to move to a comfort approach, and plans for discharge were halted. The patient never got home. He never got to his place of safety, and he died on August the 9th. Next slide, please. I've just added a countdown here to show that of all of our patient demographics, our frail elderly patients are the ones with the least amount of time on this earth, but they are expected to wait the longest, not solely by health, but also by social care, and it seems the political agenda is low. The quality of diet and quality of end-of-life study done by palliative medicine shows us that patients discharged to nursing homes are in their last 6 months of life, and those to residential are in their last 12 months of life typically. By this stance, this patient spent near 65% of the last 6 months of his life waiting for a discharge plan, just for a discharge plan. That's not to mention then the wait for placement availability. 132 days or even a plan of discharge is an injustice, and my patient would ask us on the daily rounds if we had any news for him. Despite lacking capacity, he was still aware that he was in hospital and he longed to be home. It's sad that we weren't unable to make that happen for him. As a side note, from an end-of-life audit I've done, a large number of elderly inpatient deaths in our hospitals are patients also waiting for their social needs to be met. This patient's not alone. The question must be asked if we as a society are inadvertently ignoring the voices of our most vulnerable patients because their voice isn't loud. It's become the expected norm that our patients just have to wait. Our social crisis is arguably the newest geriatric giant. Next slide. I hate to bring this problem, but this is one of a few patient experiences I've captured, and unfortunately it appears to be more usual than the efficient discharges. I don't have all the answers, and I know that the social discharges and the challenges it faces is not new. The inward facing, the wider corporate workings of things aren't within my remit, but there are opportunities that may help. If everybody did 1%, this would lead to a wider impact. For example, instead of pharmacy needing 48 hours for a blister pack, could this be done in 24? Another side project I'm currently working on is to be a Coty Link practitioner with palliative care services and look to highlight the work that can be done around advanced future care planning to reduce the number of unnecessary admitted patients, stopping the problem before it starts, and empowering our patients' choices and wants. I'm currently also seeking a way through IT to have advanced future care plans uploaded to the Welsh clinical document, as WCP is now visible to GP out of hours and the Welsh ambulance services, meaning that out of hours emergency responders would have quicker access to established discussions around the patient's wants and wishes. The acute care of the elderly unit in Princess of Wales Hospital is a huge success, led by Dr. Wendy Mashland, ACP, which aims to treat and discharge patients before they get to the wards. I know this is also looking at being adapted in the Royal Glamorgan Hospital, and there's work being done to include this in Prince Charles. We trialled the discharge to recover then assess on Ward 19. In my patient's case, this would potentially, in the early stages of the admission, save 38 days for the patient waiting an allocated social worker, because simple packages of care don't need a social worker. However, as it progressed, it was clear that he needed a social worker. The D2RA model is great, but unfortunately, certain patients are still going to be waiting in hospital for care, despite the pathway saying they're dischargeable. Many socially admitted patients are here as the last point of contact of help and are at crisis level at home. Bridgend locality particularly has very limited and little availability for placements and packages of care, even when comparing to our neighbouring counties. I'm told that after 2 weeks of admission in Bridgend, patients lose their established package of care, where this may be a month or more in our neighbouring hospitals. Additionally, the pathway states that pathway 1 patient should return home with short-term support. There is no support. Pathway 2 states that patients should not be admitted to an acute hospital bed, but to a rehabilitation unit. We have no non-acute hospitals in Bridgend, meaning that this pathway is ultimately impossible for us to follow. The proposed HAYS programme, created by Julie Hayes, lead ACP, looks to have a pool of healthcare support workers that are either ward-based that rotate or linked directly with wards, who can be utilised and provide simple support in the patient's own home, dehospitalising and mitigating the iatrogenic impact of hospital admission, as well as reducing the cost of an acute hospital ward admission. In the Chancellor's budget, announced at the beginning of this month, they have invested over £3 billion to improve the efficiency and productivity of our current NHS infrastructures and IT systems. We may not be able to make care available, but whilst we're waiting, we could utilise and invest in our existing workforce so that the wider cost of inpatient admission and bed pressures could be reduced, as well as reducing the inherent risk of prolonged hospital admissions. I don't think we can keep keeping patients in hospital when a simple package of care is all they need. Wards are most busy in the morning and the evening. So like central government, could we not think differently and use the staff we have, care for patients in their own homes until our formal care packages can start? An intermediate initiative, a ward at home. We don't have a policy for social admitters in CTM. We have the equivalent of a full acute hospital of social patients, and I don't think it's unreasonable to have expected standards, be it targets for early discharge intervention or expectations that assessments from our wards, although done usually very good, are done within an agreed and specifically an auditable time frame. This includes targets for discharge planning meetings and best interest meetings, despite ward speciality, because discharge planning should be everybody's business. I understand a lot of intra-organisational agreement would need to be had with social services, but agree on reasonable timeframes for allocations of social workers and assessments would be so beneficial. So patients like this don't need to wait 92 days for this simple thing. It is not uncommon for social workers to visit my patients 2 or 3 times to assess them. Why can't this be done in one visit? We may be recording expected dates of discharge and length of stays, but aside from length of stays, recording and reporting the impact on patients' welfare and highlight this values-based impact that this issue has on our patients, both physical and mental well-being, would give it more weighting. If we are not reporting this, how can it be reduced? And finally, coming from an ED background, I know a lot of priority is given to emergency care, and rightly so. But the flow is at the back door, and this is not a new problem. Initiatives like the ACE unit have been so beneficial, And perhaps adding a COTI practitioner presence within the ED departments may mean quicker interpretation of investigations for frail elderly patients, as well as a senior frailty input for early frailty discharges. Putting the patient first is what needed. Could there be pressure from health and social care on local governments to make social and nosocomial challenges as reportable as other geriatrics like falls and pressure damage? If the issue isn't reported, who's answering it? The Community Resource Care Division within Bridgend County Borough Council has 150 20-hour care contracts. They have 66 vacancies and 18 of them are on long-term sick. If we highlighted the harm to patients and pushed the need back to Welsh Government, investments in social care could make it more desirable. Social care is competing with supermarkets and staff. But where there is a harm, there is a greater need. Next slide, please. So thank you for inviting me to share this patient's experience and to give him a voice. With very little friends or family and with a cognitive impairment, this patient was vulnerable, and having his case highlights helps make his voice heard. We may not have locks on the doors, but through disability, illness and immobility, our patients are not free to physically leave. Are we inadvertently as a society also depriving our elder members of their liberty by allowing unmet social needs to go unreported and unchallenged? This image is quite powerful because it also draws our mind back to recognizing that despite their advancing age, these patients are us and we are them. I think rather than expecting patients to wait months in hospital, we need to help them enjoy their last months of their lives. And after all, it's only a short trip and we should help them enjoy it too.
Yeah. Adam, thank you very much. That was an extremely powerful presentation, in many ways quite harrowing, to see the impact that the entirety of our system has on individuals who are, as you rightly said, in the last period of their lives. A significant chunk of that is spent, attempting to navigate a system that is there to support them and their needs. Some very powerful messages. I think a lot of this will resonate with the work that's being done by colleagues around this table, not least Matt, Linda, Paul, Gethin and others, in trying to identify where there are those opportunities within our health system, but also between our health system and those who have the statutory responsibility for delivering social care services, to try and find a way of really addressing some of these quite significant challenges. Any particular questions to Adam? Linda, sorry, Karen.
Thank you. And obviously we have heard this at Quality and Safety Committee, and we can see how powerful it is, and it's no less powerful the second time.
Yeah.
I just wondered whether, because I think it has such impact and it illustrates so perfectly the harm and the way we need to look at this differently, whether when we are in joint meetings with social care, and whether it's regional partnership or whatever the forums are where we're looking at working jointly, can we use this story or a similar story as an opportunity to just make sure people are totally focused on what this means, because it's not just a statistic, it's our families, it's us potentially, it's that quality of life thing is so important. So I just wondered if there's maybe that does happen, but I think it would be very impactful to look at how we can work together more closely.
Thank you, Karen. Linda.
Yeah, thanks so much for that. I mean, that's just like.
I think you're on mute, Linda.
Oh, I'm. Can you hear me now?
We've got the screen on mute, have we?
No.
I'm not on mute, so.
Yeah, sorry, Linda, we can't hear you. I'll try and come. We'll come back to you. Okay. Greg.
Yeah, thanks, Adam, for telling the story. It really does break your heart to hear it. And we know, as you rightly said, there are many other patients, sadly, in this position. I think you made a really good point around moving away from, we have 200 plus patients medically optimized to move on, but changing the narrative to the harm caused by patients that are deconditioned. And we have had some discussions with Welsh Government colleagues and NHS exec colleagues in relation to how can we properly land on some metrics. We talked about hospital-acquired pneumonia as a good nosocomial example. How can we properly measure that as a harm event across the health board with patients that are deconditioned? And we do know that we see an increase in falls, we see an increase in pressure ulcers for patients that are medically and therapy optimized. But I think changing the narrative, you know, to colleagues across the system away from numbers to harm events would be a really good place to go. So thank you, Adam, for telling the story again. I know you're a bit nervous coming into the board, but you know, you articulated the story beautifully, and you know, whatever we can do, you know, as a board to really commit to properly trying to sort this problem out, you know, the chair and everybody, I'm sure will have that. So thank you.
Thanks, Mike. Gethin, and then Ian, and then Linda.
Adam, thank you. That's the second time I've heard that story, and it really is heartbreaking. And you know, and it is so important, isn't it? Because every one of those numbers that we often talk about is actually a person, and it's a person with who's had you know, a life and has a life to continue to lead for however short. And I guess, you know, there's two bits really that your presentation also draws out. I think the first is there is a perception, isn't there, that hospitals are safe, and hospitals are safe if you're sick, but they're not safe places if you're not sick. And I think we've really got to help work with our partners, with the population at large, to understand that, you know, if you don't need to be here, being in a hospital is one of the worst places for you to be, because the risk of infection, the risk of deconditioning, the impact on your mental well-being, all of those things are so apparent, aren't they? And I think the other bit is also that understanding of the data you shared around life expectancy when you're in a nursing home and life expectancy when you're in a residential home, because I think, again, it's a really difficult conversation to have with families. It's a really difficult conversation to have around, you know, there are things that we can do for your loved one, but sometimes being able to support your loved one to stay where they are is the right thing. You know, and you know, I reflect on some of the stories I get from the clinical navigation hub and the interventions they're taking. I think there were 4 patients that ambulances were called for yesterday who were all in their 90s, all of whom, because of the intervention of the nav hub, didn't get then conveyed to hospital and were kept safe in their own home. And I think it's really important that we understand that. And I think there is a conversation that we have to have with ourselves, with all our teams, with our partners, and more broadly around how do we provide the right care and the most respectful care for our older people. And those that really do need to come into hospital absolutely should come in, but we also know that for some it's the wrong pathway, and we need to be able to support those patients in a much better way. But thank you.
Dom, on this point.
I know I'll follow on for
Oh, sorry, okay. Ian.
Yes, simple question, really. Yeah, I was very moved by that, actually. I think we, anecdotally, a lot of us know of stories similar to that in the community and so on. I suppose my question is fairly simple: are we as a board learning from some of these mistakes or ideas you came up with? Some of the ideas you came up with there were great, I think, in order to sort of alleviate what's taking place. So are we as a board learning from that? I'm not expecting you to answer it, but I don't know who's going to answer it, but it'd be interesting for us to sort of follow on from this and to see if we're getting better.
Yeah.
Ian, I'll bring it forward.
Yeah. So Ethan's going to give a bit of an overview a bit later on today about some of the challenges that we're seeing around the flow of patients through our hospitals, and I think I voiced this when I met the 3 council chief execs a few weeks ago. You know, and it's rarely I get to a point of thinking I don't know what more we can do, because we've got this intractable issue where we can just see and hear every day, and as Ian said, and you know, every one of us would have a story about somebody we know who's been in a similar situation, or a family member or a friend of a family member, and we all know these things aren't right. Having said that, I think there are things we can do. There are things Adam's just described there, a number of initiatives. I think there's something about, in the short term, if we can't solve the problem, how do we make the experience for the patients who are in this situation as good as possible? And we've talked before, Greg, haven't we, and with Lauren, about, you know, do we need to think about different models of workforce
skilling up our healthcare support workers around reablement and things like that. So actually, as well as doing the sort of core business of care, there's an opportunity under the guidance of physio and OT to sort of be mobilising the physical environments. Often are not great for our patients. I've seen some really great examples going around different sites of how we've tried to make it better for people, you know, getting people up to go sit at a table to have their food rather than sitting in bed with their, you know, there's lots we can do. It's not what we want to be, but at least if they are here, whilst we're trying to solve the problem, how to make it better. I think we've also got to think for next, I mean, we have these pressures all year round, don't we? But winter is always more challenging. I think over the next 4 or 5 months, we need to bring together colleagues like Adam, colleagues from community facilities, therapies and others together and say, how could we do something different? Because I absolutely agree with you, Adam. We are already funding these people to be looked after, but we're funding them to be looked after in the wrong place, which is in the acute hospital bed. So we collectively need to think, well, could we be better using that money that we're currently spending in a different way? Should, you know, I was at YCR the other week and I had people telling me that they'd had 40 odd applications for healthcare support worker jobs. Yet we're being told that domiciliary care, we can't attract anybody. Well, then what are we doing? We need to be thinking differently. We need to design a different type of role for people in the community that, as you just said, was sort of like a reablement worker or an intermediate care, whatever we might call them, something that is attached to maybe the community nursing teams or whoever, who can be that bridge between a long-term ongoing package of domiciliary care, but enables them to be able to get home quickly and turn them, you know, do what we need to do in hospital, but then get them back home, supported in their own environment. And I think we've got to set ourselves a challenge over the next few months to come up with a plan that says, how will we do that for the next winter? Because we cannot continue to be hearing these stories on a daily basis from patients and families and practitioners that we all know is just not the right care for these people, and let alone all the other consequential impact of that very old person who sat in the back of an ambulance because they can't get into the bed that they actually need, you know. So I think, you know, we do have to take the challenge, I think, from today's meeting and say, and I would suggest to Ian's point, what the board should be suggesting is that we bring back a plan to the May board of how we're going to do some proactive change over the next few months that will aim to try and alleviate some of these issues that Adam so eloquently described.
That's Paul. I think fundamentally enough is enough and something needs to give really quickly. Linda, I'll come back to you again online, just in hope that we can hear you. Okay.
Right, can you hear me now?
Great. Yeah, thanks, Linda.
Amazing. Okay, great. I think it's just following on from what Ian and Paul said, actually. It feels like now we can't be using words like this is heartbreaking, this is terrible. We have to say it's completely unacceptable, because actually we hear these stories all the time and I feel like we need to move into action. So I think it's just reinforcing that point. And I was just wondering, there's just been a couple of models I've seen recently. Obviously, Paul, when we went up to YCR and we saw that lovely little ward that you're using now for help with the healthcare assistant based, is there more we could be doing around that? Also, I was at a hospital recently where they actually, this is a big acute hospital where they actually have 2 whole wards devoted to frail elderly patients. And it sounds awful, but they've accepted that social services are not going to be getting the patients out of hospital. So they've made the environment really fantastic with, as you said, people eating at tables. They've got lovely jigsaws and puzzles. Everyone's got individual blankets, for example, and they're little things, but it was a really lovely environment. It's a very expensive model, and I'm not saying it's perfect, but that was definitely better than just having people, you know, randomly in beds. And the other thing I was wondering whether or not CTM had really looked closely at what's been happening with some of the virtual wards step up initiatives that are happening in England. There are some non-digital step up interventions which might be applicable for some patients like this. So yeah, I mean that's all I wanted to say.
Thanks, Linda. Geraint.
Well, I certainly want to agree with Linda's point that this is beyond heartbreaking. It's outrageous, actually, and that, you know, we're living in the time that we're in, and this sort of story is presented to us, which we know is too common and has been for too long. But this is not a new discussion. You know, those of us who've been around the local government and health world for quite some time know that this issue is returned to time and time again in regional discussions, in national discussions. We cannot do this in isolation as a board or as local government. It has to be joined up, and there has to be a massive reinvestment in community, lower level community provision, which will take pressure off hospitals, improve patient flow, and also have an impact on individuals in our communities, like this tragic situation with this poor old man who suffered so badly in the last few months of his life. It's a disgrace that we should be still having this discussion. And I would urge colleagues, anyone who are working with people in my sector, the local government sector, health at the regional level, look back at things that we've done in the past. We did have arrangements, certainly before COVID. There was some really good work being done on preventing admission to hospital and enabling faster discharge, even at the point of accident and emergency, before people even go through the next doors into the hospital. But there does need to be a massive reinvestment, and I think this is an example where, lots of people think that austerity is this abstract sort of thing floating around, but it actually has a real human cost. And the pressures, I'm sitting here listening to, the length of time that it takes to get a social worker even allocated, never mind for the actual assessment to take place. It's a disgrace. But we must recognise that every single sector now of our society, these sort of services are under massive pressure. They are creaking. We cannot recruit people, and the resources aren't there. And there needs to be an urgent attack on this issue. And I don't see the urgency anywhere at the moment.
Paul and I will be attending a meeting of the full council at RCT in a couple of weeks' time. And I'd be very happy for us to share this story, if it was appropriate, as an example of where the system simply isn't working, so that collectively county councillors involving the cabinet and members of the scrutiny committee, along with us and the health board, can say publicly in what is a public forum that this is unacceptable and that we collectively need to commit ourselves to solving this. There are a range of challenges to work through, but this should not be beyond our ability.
Yeah, and I agree with you. And the challenge with this whole conversation is it's not trying to blame one part of the system or another part of the system. It's a collective problem we all have, but you cannot get away from the fact there are some bits that are statutory responsibility, and we can't, as health professionals, start assessing people for complex social work issues. Having said that, there are opportunities for us to look at the people who don't necessarily need a full-blown social work assessment. So the gentleman that Adam was describing there, who obviously made a best interest meeting, or that does need really experienced social work input. But there are a lot of patients who are waiting for things that probably don't need to have a highly qualified and experienced social worker. They need to have people who know the criteria against which people get assessed. They need to have clinical input. And I think there is something here about, we talk, I'm on the Ministers for Care Action Committee, and we're talking about trusted assessors. We've got very low numbers in CTM of trusted assessors. Why can't we skill up a load more people in our settings to be people like Adam could be a trusted assessor? Frankly, there are people out there who could assess on behalf of social care for simple stuff, not saying complex, difficult stuff, but if we've got trust between local authority, health, and we want to do this together, those people, we should be able to expand that, because actually the biggest delay for this was the gentleman not getting the assessment, and actually if we could have cracked that bit, and if the social workers can then be freed up of some of the lower level stuff so they can focus. It's the same way that we talk in health and get the practitioners to only do the stuff that only they can do. We need to be thinking about that from a social care perspective as well. And the trusted assessor model was designed to do just that. But if you look at our numbers of trusted assessors in CTM, we've got a very, very low number compared to other people around us. So there's something, as you say, this isn't about just us trying to do what we can do our own. It's got to be a collective effort. There is some really good stuff. I don't want people to think we don't have capacity. We've got some great examples across our health system of the ACT team in Bridgend. We've got the Stay Well at Home team in RCT and Merthyr. I think the challenge is we just haven't got the capacity. The capacity of those teams is now reached, and they are then having to say, well, we haven't got the capacity to take these people. So there's something about what can we do to increase capacity at that intermediate stage to enable some of these people to be got home quickly as possible. I think it needs to be done collectively, but I also think honestly, we also have to drive this quite hard from the health perspective, because the impact of this is being felt most acutely on the patients who are sitting in the acute hospital beds, and that for me is not something we can tolerate.
in the beds. That's wrong. Linda, did you want to? You raised your hand earlier. Was there a?
There's a lot going on, and there's a lot we could say in response, but I'll hold back on some of that. Because some of it actually will coming up later in the agenda too.
Yeah.
Adam, you did though have some good ideas which I hadn't heard before about some health related actions that could be undertaken. And I just wanted to understand if you're connected into, there is a joint local authority and health improving discharge programme board. And I don't know if you know how to feed into that. And if not, we'll help you.
What is it called?
I think it's called Improving Discharge Board. It's joint with local authorities. It's where we look at what the hold-ups are and what ideas we could bring forward.
Yeah.
But I think you did have some good ideas there, which were new to me. So let's hook you in and make sure that they're fed into that.
Sorry, Nicola.
Yeah, thank you, Adam. I heard that for the second time. I think it's more difficult to hear face to face. You touched a little bit, Paul, on what I was going to say. Adam talked about 60 or 66 vacancies within the healthcare support workers. I know we have trialled this previously and we didn't have much success, where we would employ, so they would rotate between social care and in our acute setting, so that maybe that gave them a way of developing, help retain them, made them feel of more value. So maybe we need to relook at that model again.
Yeah, definitely.
We have huge amounts of applications when we advertise for our healthcare support workers. So there's definitely a market there, isn't there?
Well, it's a piece of work we could be doing jointly with social care to say, how do you create a career pathway? So somebody might start off in domiciliary care and have the potential then to take on additional skills and train. They might rotate in. It's not about trying to steal staff from one place to for another. It's about how this is a big workforce challenge. We all know is what the issue is. So how do we create opportunities for people that are attractive propositions that give people career development, and also, provide additional capacity at the most important part of work where we've got, which is in our communities, but under the guidance of nurses, OTs, physios, so they're working to a clear programme of work.
Yeah, the advice coming at the end is most people have already said what he wants to say. So I just wholeheartedly support what Gethin, Greg and Linda said, and Paul summarised as well. I was going to talk a bit about the experience and re-enablement. But the one final point I just want to make was about the deconditioned patient is that we tend to talk about deconditioned in terms of the physical, but the mental is just as important and actually drives a lot of it as well. Particularly when you have confusion added into it, they can't just walk off the ward because immediately you're worried about them, you pull them back onto the ward. And the statistic I got from years ago's training was 4 years bed rest. They use 12 hours of rehabilitation to get them back to the state they were in before. So if you can start doing the maths of that for this poor gentleman here, then that just is considerable, really. But I think the stuff that Linda points out about YCC, Ward 3 in PCH as well, trying to do that on an acute setting. Dilys and I went to go and see them as well, and it was fantastic what they did. Simple little things, but made such an impact about bringing those patients in, and that's what we must start thinking about really for all our wards, on top of all the other pressures that we've got. I know there's more to do, but thank you, Adam, and I'm really keen to catch up about this. That's some things we can do.
Thank you, John. Much appreciated. Adam, thank you for being with us this morning. I'm really pleased to be able to devote the time to what is an extremely important subject, and thank you for sharing the patient story, which is something that really has hit home today. To reassure you, there is a lot of working on, but it's whether we've got the pace being put into things that need to change.
So Adam's the first each piece of presentation. It might have a common theme here. So we've got Matt come to talk about the health and social care integration work, and Gethin talking about sort of patient flow and challenges around patient flow. What I'd suggest is at the end of today, board, back to Ian's point about what are we going to do concretely as a difference from hearing the story, because frankly there's no point bringing these stories unless we're going to do something. I think we will get some action together. We'll probably be back in contact with you, Adam, I think after today, to maybe get you involved in that work, because I think what I'm thinking about is maybe we need a small focused group that is charged with developing some proposals that we can bring back to the board in May to close the loop, to show the board members that the actions we're taking to try and mitigate some of these issues, they're not easy to solve. Some things are going to be difficult, but there are some, despite that, there are things we can do. And I think it'd be really helpful to be able to convene a little small group together to bring that back.
So it's a good way forward. Thank you, Paul. Okay, thanks, Adam.
Thank you.
Thanks,
Adam.
Adam.
Thank you. Okay, we'll move on to item 4. Item 4.1, my chair's report, which is for noting, and there's an item there in terms of asking colleagues just to endorse the fixing the common seal. Can I just point out in my chair's report, since we last met as a board, we have a new Welsh government with a new First Minister, and I congratulated Vaughan Gethin on his appointment as First Minister for Wales. Since drafting the report, Eluned Morgan has been reappointed as the Cabinet Secretary for Health and Social Care. Dawn Bowden, who of course is one of our Senate members representing the Merthyr Tydfil and Rumney constituency, has been appointed as Minister for Social Care, and Jane Bryant from Newport has been appointed by the First Minister as Minister for Children and Mental Health. So we have new ministers in post, a continuity of cabinet rank, which is helpful because the Minister knows the lay of the land and knows the service back to front. So we will be arranging a series of meetings over the next couple of months, not least with Dawn Bowden as Minister for Social Care, to further talk through the sorts of areas of work that we're doing as a health board, but in particular where perhaps we can collectively with social care in local governments to address some of these challenges. Can I also just point out that as of April, which starts on Monday of next week, we have a new board member. So just to confirm that Rachel Rowlands has been appointed by the Minister as our newest independent member community, replacing Mel, who concludes his term on Sunday this week. So very grateful to Mel for his years of service to the board, and very much looking forward to welcoming Rachel into her new post. That's all I wanted to flag up this morning. Are there any questions on my report? No. Okay. Thank you. Thank you very much. Can I also move on to item 4.1.1, the action log from the previous board meeting? And if I can just check, it is for noting, and those things that are open. Any updates on the action log from any colleagues in the exec team? Don't think there's anything that was there. Most things are in progress. Yeah.
Nothing's in progress.
So nothing to update colleagues. No. Okay. If colleagues can just note the action log, thank you very much. Item 4.2, the Chief Exec's report. Just to say, Paul's got his report on the agenda, but there are some additional matters as well in respect of the corporate parenting charter that Paul wants to touch on, and to also update the board in respect of the work that's been done in respect of the emergency medical retrieval transportation service known as the air ambulance service. So Paul, I hand over to you for your report.
Thank you, Chair. So you'll see in there just an update on where we are on the escalation. I won't go into that again. No change on that since the last meeting. Further ongoing engagement with Welsh Government around that. Waiting pending the next tripartite meeting to review escalation status of all health boards. Yeah, the chair mentioned the corporate parenting charter which we brought here. There is corporate parenting charter now being produced by Welsh Government that is being adopted by many public sector organisations across Wales, and very much encouraging health boards to participate in this really important work to support children who are and young people who are in care or coming out of care, thinking about how as a health board we can support. Obviously we engage very actively with our group of young people through our health services in terms of supporting them, but also whether there's opportunities for us to think more broadly around that, and things like encouraging employment opportunities for people leaving care, helping maybe with some targeted work to help them develop their skills and expertise. So I would propose, if that was available to the board, that we would move to adopt the corporate parenting charter and sign up as an organisation to be part of it, I think it's a really important opportunity for us to, and particularly in our part of the world where we know we've got some particular challenges, I think it's a really important demonstration of our commitment to working with this really vulnerable group of young people. So what I've proposed is that we adopt and sign up to it, and that we'll bring back a plan of how we'll go about sort of working with that, under that, whether that's around employment, whether it's around direct health provision for those caregivers, and potential opportunities for liaison with training development opportunities as well. So we plan to bring something back at a later date to the board, but just wanted to bring that first of all. So if everyone's okay, we'll agree to adopt that.
Yeah, thanks, Paul. Just on the corporate parenting charter, this is being adopted by other health boards. I think it's right as a public service that we sign up to things that we can do. And as Paul said, there's already the ambition to support people into employment as one example of the sorts of things we are able to do as a health board. So if colleagues are happy to endorse us signing up to that, I know that ministerial colleagues are keen that all health boards do so. So I don't see any objections. So yeah, thank you very much.
Thank you for that. There's a brief update there about ACSP, and we may well come back to that bit later on when we get about the plans. And then obviously importantly today there is a whole raft of papers, and apologies for the length of the board papers, which as a consequence of the new establishment of the JCC. So as you'll know, from 1st of April, we will be establishing across the NHS in Wales the new Joint Commissioning Committee, which will replace the WISC, the Welsh Health Service Specialist Services Committee, and EASC, the Emergency Ambulance Service Committee, as well as the NCCU, National Commissioning Unit. We, as you know, host all these entities currently, and will continue to host from the 1st of April the new Joint Commissioning Committee. Both the chair and I sit on the oversight board of the establishment of the Joint Committee, and Gareth has been very active in the governance work stream with board secretary colleagues, particularly the board secretary from Anar and Bevan, and has worked very actively on developing the accountability agreements and arrangements for the new Joint Committee. We've now the necessary legal directions have been laid with Senedd, and we've now had direction from the Minister to adopt the establishment order and standing orders, SFIs, etc., for the new Joint Committee to come through our board, and they're going to all of the other Southern health boards, remembering this new Joint Committee is a joint committee of all 7 health boards across Wales. We have also been going through the process of appointments into the new Joint Committee at the Tier 1 level. I'm pleased to say that we've appointed on an interim basis Abby Harris, who is currently the Director of Strategy and Planning at Cardiff and Vale Health Board. Abby has been appointed as the Interim Chief Commissioner for the new Joint Committee, which I think will be a really positive step forward, bringing her expertise both from NHS experience, local government, working policy in Welsh Government, and with a commissioning background and planning background will be a very important, I think, skill set to bring into the establishment of the new Joint Committee. And then we've also appointed a new chair for the Joint Committee and 3 additional lay members for the Joint Committee. I don't think yet they've been published. I can't probably publicly say, but they're imminent. I think in the next 24 hours we should be getting that confirmation. So we will have the necessary non-executive appointments in place for the 1st of April to be able to oversee the committee. And we are heavily involved as the host through our people team in the organisational change process of bringing together the existing teams of staff from WISC and EASC into the new Joint Committee, and that process is ongoing at the moment. So I'm looking to go after, do we have to formally?
Yeah, so the item later on.
Yeah, okay, fine. So that's just to say that all keys off, but I have to say thank you to Gareth for all his time on this, because I know it's been a lot of work, and also to Powell and Karen in the people team, because Karen spent a lot of her time in recent weeks managing the OCP process for this, which has been quite complicated. So thank you to them. The next item on my report relates to the Emergency Medical Retrieval and Transfer Service, otherwise known as EMERTS. This is a programme of work that's been led by the EASC, the Emergency Ambulance Committee, and particularly by the Chief Ambulance Commissioner, Stephen Harry. which looks at the configuration of air ambulance and emergency retrieval services across Wales. And just for everyone's understanding, this is, as it says, the air ambulance, but it isn't just the air ambulance. The air ambulance charity in Wales provide the equipment, helicopters, all the various infrastructure that goes with running the air ambulance service, and there is a NHS Wales component which is hosted by Swansea Bay, which are the critical care practitioners who work as part of that service. So it's a joint effort between the NHS and their ambulance service, which it brings together under the umbrella of EMERT. For a while now, there's been some conversations going on about the configuration of the bases of the EMERT service across Wales, recognising that for some populations in Wales, the access to or availability of service is not as it could be, particularly an overnight. And there's a particular problem in North Wales where a large portion of the Betsy Cadwallader and the Health Board area doesn't currently have the availability of an air ambulance overnight due to various flying restrictions and base locations and things. So a programme of work was kicked off a while back with EAST to look at how we might equalise the provision of air ambulance services across Wales and ensure that wherever possible we were to meet the needs of the population both in the day and overnight. I should say for CTM, the changes that are being considered or being developed as part of this proposal don't have a significant impact on our particular population. The biggest impact or changes associated with this proposal will be felt within the Powys Health Board area and, as I said, Betsy Cadwallader area. So we just need to bear that in mind when we're talking about this, that, you know, largely for our population, we will see a continuation of the service as it is today. In fact, it may even improve because currently at night, the only service that is provided is based out of the Cardiff base. And therefore people in CTM, there could be a scenario where somebody needs an air ambulance in CTM, but it's up in the north of Wales because that's where the ambulance has been sent to. Under the proposal that is being put forward, the aim would be to increase the capacity in the north of Wales, meaning the base in Cardiff would have more capacity out of hours to respond to local South Wales issues. So if anything, we will be a beneficiary of this change from an enhanced offer from the air ambulance overnight. I think it's fair to say there is obviously quite a bit of concern and questioning coming from particularly the Powys patch and Betsy Cadwallader area around these changes. And so there has been a proposal that we would have a conversation about this topic today at the board, and I would brief you, and we would accept and note the changes that are being proposed, but that actually there is further work to do on those proposals. And I know colleagues from Schleiss are here in the room today. I've had a letter from Daniel, which is included in the board pack today. Nationally, Stephen Harry, the Chief Ambulance Commissioner, has had conversations with the national lead from Schleiss, I think only yesterday, about the concerns. We've got a briefing conversation with Chief Execs tonight at 5 o'clock to feed back the conversations that Schleiss have had with Stephen. So our proposal would be that we want to take a further month or so to consider the feedback that's come in from Schleiss, but also to consider feedback that's come in Powys and Betsy from a number of the populations up there, but also from MSs, from MPs and others. We need to make sure we've taken time to consider their perspectives as is one thing. And secondly, the proposal to increase the air ambulance provision is also supplemented by a proposal to increase road-based provision, so rapid response vehicles in Powys particularly, to try and ensure that we provide as comprehensive a service as possible. I think it's acknowledged that there is further detail needed on what that rapid response vehicle resource would look like for Powys particularly, and Powys have asked that they would like further detail on what that recommendation will actually mean in practice. So there's some further work to do over the next few weeks just to articulate in a bit more detail and hopefully provide the assurances to the Powys population and North Wales that the RRV, rapid response vehicle capacity, will be enough to respond as and when is needed. So all we're asking board members today to do is to note that there is this work going on to look at the air ambulance provision across Wales, to recognise that there is further detail going to be undertaken over the next few weeks to respond to the concerns that have been raised, both by CLICE and other external organisations, and that the recommendation for the rapid response vehicles needs some further work. The proposed next steps would be we would have a board conversation in mid-April as boards of each of the 7 health boards, recognising that the slight complication is that East will no longer exist from the 1st of April. So this one would get transition into the new Joint Commissioning Committee. So the sequencing would be that boards individually would have conversations, recognising this will be a decision taken by the new Joint Committee, not by individual boards, but it's appropriate that each board has the opportunity to consider the recommendations separately. That can then inform the conversations that chief execs will have at the Joint Commissioning Committee, which is scheduled to take place, I think, on the 23rd of April. And that is when we would propose that a final decision will be made by the Joint Committee at that date. So, sorry, it's been a bit of a long-winded description, but it is obviously a very complicated, involved process, recognising the sensitivity of all of this change, making sure that we recognise the concern that is being voiced, particularly in other areas of Wales around these changes. I should also say there's been a full and comprehensive engagement programme which has been undertaken underpinning this, and actually CTM residents reflecting, I guess, the fact that there isn't really going to be much change. We've had a very, very negligible response to the consultation from our own population, despite lots and lots of attempts to try and engage and involve our population in the conversations. We had very, very negligible input from our community and population. So obviously I think that might reflect the fact that people look at it and think, well, there isn't much change for us, but we do need to acknowledge our colleagues in other parts of Wales are dealing with some quite significant levels of interest and conversation with their population. So hopefully that describes where we're at, and also what the next steps in the process are, but happy to take any questions on that.
And again, just for clarification, I've agreed that the board should meet on Tuesday the 9th of April for us to receive the update as to the development of the work that's clearly been taken forward over the next couple of weeks. But obviously this then becomes a matter for which the JCC will need to make a decision, because obviously the JCC has delegated functions from the 7 health boards, and this is one of the functions it has, with the transfer of the responsibility of the EASC functions into it. So my understanding, since Paul's, is that it's not for the health board to take an individual decision on the 9th of April, but we receive an update. It will allow colleagues to ask questions about the detail and in particular what the impact will be on our own health population, because that is our own health population for which we have a statutory duty, as all the 7 health boards do separately. We have no collective statutory responsibility for other parts of Wales. We are duty bound to ensure that whatever is being proposed meets the needs of the population of CTM, and I think we can explore this further on the 9th of April. Any particular questions on the process? This is slightly unusual. It's the first time a matter which has been delegated to a collective function of the 7 health boards has come to the 7 separately. But any questions on the process from board members? No. Okay. Okay. So further work will be developed, and we'll return to this on the 9th of April, and then obviously the matter will be considered, as Paul said, by the JCC towards the end of the month.
Okay, fine. Thank you. Just a couple of other final points as well, just to say that this week, really positively, I signed the Armed Forces Covenant on behalf of the Health Board. This is to reflect the work that we want to do collectively with both the armed forces, but also particularly how we can support veterans across our services, making sure that we provide the right sorts of services for our population. Interestingly, we have from the Valleys communities quite a high number of people that join the forces, and therefore consequently have quite a high number of veterans that come back in. So there is quite an important programme of work we need to be thinking about how we might continue to improve the service. We have a dedicated veterans liaison person within our team who works with that community and the voluntary sector groups that work with them. But also there is much that we can do to think about how we might play our part in helping reintegrate veterans into civilian life, particularly around employment, and looking for opportunities where we may be able to offer the routes into employment for that particular group of people. I know there's already some work going on with our teams on that front, so that was a really positive thing to do. And finally, just to say also in terms of our Seren Awards, as you'll know, we launched the Seren Awards last September. This is our Staff Recognition Award. We're now nudging 1,000 peer recognition within our Seren Awards, which is really, really positive, and honestly a real breadth of types of nominations from all sorts of parts of our organisation, all types of roles. Really, really great to read on a regular basis. And every month we then have a process where we nominate one of those nominations to be the Seren of the Month, who are celebrated, and we've had a range of people already celebrated, ranging from nurse leading on our HIV service to mortuary through to a midwife. So all sorts of different people being recognised, and really positive feedback from those colleagues who've been recognised about they were surprised to have been nominated because it's been nominated by a colleague, but B, also really grateful to have had the recognition, particularly for some of our teams that are often beavering away in locations that aren't sort of on our main sites and perhaps go a little bit under the radar sometimes. It's a really great opportunity to lift up and recognise those staff from across the organisation. So continuing to grow and develop our Seren process is really important to us. As you said there, we've got a Welsh language version of that going on now as well, and we'll obviously want to continue this momentum to maintain the number of nominations coming through.
Okay, any questions to Paul on the remainder of this report? No? Happy to note. Okay, thank you very much. Thank you, Paul. Item 5, governance, risk and assurance. We've got a number of items in front of us this morning. I think the 5.1 first, the board committee and advisory group highlight reports. And the first report at 5.1.1 is the quality and safety committee highlight report. And just to ask Carolyn if there's an update on the committee. Thank you.
Yeah, thank you. I mean, a couple of the items under alert, obviously, the first one we've already discussed in detail today, so I won't mention that. The Right Care, Right Person initiative has been looked at by the board, and we noted, I think, our most recent board that there's a good group working on that and looking at the risks associated, so we were assured by that. I'll take the rest of the report as read. I did just want to point out that we are keeping a spotlight on sepsis. Sepsis is something that causes great concern, and we as a committee have made a commitment to continuing to review that. And on a positive note, we have reports now from the care groups, which are very well put together, very succinct, and that seems to be working really well. And also the organisational risk register, which also seems to be working really well. So we've seen a marked improvement in that reporting and the interaction with the committee. So just wanted to note that. Thank you.
Thanks,
I'm happy to take any questions.
Any questions to Carolyn on the highlight report? No. Okay, thank you. Colleagues, happy to note the report. Thank you very much. 5.1.2, Digital and Data Committee highlight report. Ian, can I pass this one to you? Thank you very much.
Yeah, thanks. I'll take most of it as read, but there's a few things to comment on in terms of the alert escalate part of it. They're positive, they're not negative alerts. The first one is members will have been aware of the Information Commission Officer's Audit Action Plan, which we were a little worried about before the Christmas period, and it was a deadline coming up in January where we had to meet quite a large number of recommendations that had come out of that. And we were having a lot of problems, mainly due to our staffing at that stage. But we're pleased to report that we made significant progress towards the 35 recommendations that were made, and it's got a stage now where the ICO has formally written to the board to say that audit process is completed as far as they're concerned. But there is an action plan remaining, however. It doesn't mean everything's done, but we made significant progress towards that. So that's a very pleasing report. And in parallel with that as well, the capacity of our staffing related to that has improved, and all the positions now that we're looking to appoint to have been appointed to. And so therefore that mitigates the current risk we've got on our organisational risk register as well. So other things people can see there, so I won't go into any of the detail.
Thanks, Ian. That's really helpful. Any questions to Ian on the digital and data highlight report? No? Okay. Board notes the report. Thank you very much. Next item is a stakeholder reference group highlight report of the 8th of February. Linda, thank you very much.
I'm the lead exec for this in Aaron's absence, unless somebody else was. You can see from this, there's two main things to note actually. One is the discussion around changing the meeting frequency to the minimum of 4 a year, but potential to have another one if issues arise. So that does meet our statutory requirements. But board are asked to ratify that. And the other thing I was going to note, Jonathan, is that this is one of the areas where we tried hard around the eMerts engagement.
Yeah.
A big presentation there and discussion there.
Okay, thank you, Linda. Any questions to Linda? Are colleagues happy with what's been suggested? Yes. Okay. Thank you very much. The hosted body is Audit and Risk Committee highlight report on the 22nd of February. Thank you, Patsy. I'll hand to you for this one.
Just a very brief one on this, to assure the board that all the outstanding actions and recommendations will be included within a legacy document passed to the JCC and then continued to be reviewed through the audit committee for hosted bodies.
Thank you, Patty. That's very helpful. Any questions to Patty on the highlight report? No? Colleagues happy to note the report? Yes, thank you very much. 5.1.5, the Audit and Risk Committee highlight report. Again, Patty, I'll come back to you on this one as well. Thank you as the chair.
Okay, thanks. Just 2 points on this. A very detailed conversation was held at the Audit and Risk Committee on the JCC with a representative of Welsh Government, and some of the details are included in the paper later on today. Also, there was a referral from a proactive piece of work that the local counter fraud team had completed, and the referral is to the current People and Culture Committee on the employment of agency staff, and some of whom were working multiple shifts back to back and sometimes simultaneously. Clearly that presents a quality and safety issue. So that issue was referred to the People and Culture Committee in its current form. I'm sure we'll see from the paper later that we will that committee will have time to deal with this referral. If not, it will be passed on to subsequent committees and then handed back with a resolution to the audit committee.
Thank you, Patsy. Much appreciated. Any comments or questions for Patsy on the highlight report? No. Thank you. Okay, we'll note the report. Thank you very much. Item 5.2 is the escalation status update. We put this as a routine item on the agenda, but Paul has updated the board in his chair's report. Unless there are any further questions on this, I'll propose to move on to 5.3, which is the board assurance framework. And Gareth, I'll hand to you for the approval of this. Thank you.
Yeah, thanks, Chair. Yeah, morning everyone. So this is a regular report we bring to you in terms of the board assurance framework and apprising you of any updates to that. As always, this is underpinned by the organisational risk register. So again, just a big thank you to everyone who's involved in the updating of this process. In terms of substantive updates this time around, strategic risk 3 around finance, revenue and resources. As we're forecasting a break-even control total, that risk score is now reduced and the target scores have been achieved. So we're proposing a risk at this point. In terms of other updates, a new strategic risk on capital estates is being developed, and the people team are doing a thorough review of all the risks relevant to that service area as well. So those are the substantive updates being brought to you today. So what I'm looking for the board is to approve the updates to the risks outlined in the BAF, which are in the red text as usual, and also to the update to strategic risk 3, which is a proposal to close that risk. Thanks, Chair.
Thanks, Gareth. ask members if they have any questions to Gareth on the board assurance framework. Can I also thank Helen for submitting 3 questions in advance of the meeting in relation to the board assurance framework. They've been responded to by email, but just to assure you, Helen, both the questions and the responses will be included in the minutes of the meeting, so it will sort of complete that circle. But so thank you for doing that in advance. Any other questions to Gareth? So, Kath.
Yeah, can I just ask around the financial risk score? I mean, great that it's going down or closing. I was just wondering how we continue to monitor it, because obviously, you know, monitoring our finances is going to be essential, isn't it, moving forward?
So we'll reset at the start of the year.
Right.
And then there will be, if you look at where we are with our IMTP and financial plan, that shows a balanced plan, but with risk, and that risk unmitigated at the moment is around 9 million. So that will feed into next year's risk resetting of this risk.
Okay, so we reset the risk.
Yeah.
Okay, thank you very much. I'm very pleased to see, I say very pleased, but good to know that estates is on there in terms of the risk. I'm not very pleased to see it, but good to know that it's on there. It needs to be there. Yeah, thank you. Thanks.
Okay, colleagues, happy to approve the board assurance framework? Yes, thank you very much. Item 5.4, working in partnerships report, and I mentioned earlier that Matt has joined us to present on implementing a regional model of integrated community care services. For those of you who don't know, Matt was one of the deputy directors in the health and social care division in Welsh Government, but in the social care part of that. So Matt has been known to a number of us in this room for many years, but is doing sterling work as our Director of Integration. So just, Matt, really good to see you. As I mentioned earlier in my introduction, we'd be delighted if you wanted to come to future board meetings. There will be a standing invitation to you, because I think the conversations, in particular the one we had earlier from the presentation from Adam, you know, I think that's going to, I think much of this now has to be really led by the board. So I think having you engage in those conversations will be terrific. So I'll hand over to you. Really good to see you.
Thank you, Chair. I'd be really keen to accept that invitation. And if I could spend a few minutes on the presentation of meeting management, that'd be grateful. I think it follows on quite well from the presentation we had from Adam at the top of the meeting. That was a really stark example, wasn't it? It shows how our system has really struggled to manage the challenge presented by the growing number of older and more frail people that we have in our population. As you know, that's a population group that's going to grow over the next number of years. 10% of the population of Wales in 2021, projected to move to 14% in 2041. And this is a great success, of course, and something to be celebrated. On the one hand, the more people are living longer into old age, but as we've seen already this morning, it presents from a public service lens real challenges to us. Wales isn't the only country that struggled with this. Other countries with a similar demographic profile, of course, find themselves in this situation. For this population group, it's the continuity and coordination of care that's absolutely critical. And that's the reason why a whole system approach, well-being, social care, healthcare is absolutely vital. So that's the context really then for the presentation, which describes to you in quite outline form in the short time that we had this morning, but the development of a programme of work on an integrated community care system in Cwmtaf Morgannwg region, which is an endeavour that's been convened through our regional partnership board. So, you know, really good joined up working on this. My role, I think, is quite a unique one. I kind of equal shares across the 4 statutory organisations on the patch. So I work to the 3 local authorities under the health board, 2, and I've been in post since December to move this work forward. So I think when we ask people, and this is the most important thing, isn't it, what matters to them, most of the time they'll speak of being supported by health and social care services to live as independently as possible in their community and attain the maximum quality of life that they're able to do so. Community health and social care, integrated community health and social care is really, really important. One of the problems that we have is the way that our services in the community have developed has arisen to a very complicated pattern of services. So design decisions taken individually by service leads, sometimes in a not joined up way, other times because of quite narrowly defined national funding streams, which we responded to, but that's been done in isolation. If I can describe that as the organic development of community services, that's resulted in a huge complexity approach. There's great variation, and that's confusing for the general public. It's also confusing for our clinicians, incidentally, when you ask them. It's one of the biggest challenges that they have. Navigation in our system is seriously tough. So if there's an idea then that lies behind this programme that I'm leading, is can we move from this position of complexity to a set of community services more led by design, based on a once for CTM approach, an optimal model for our citizens. So there are some questions that go with that. What is this optimal approach to address what matters for people? Can we describe that? Can we develop an effective transition plan? And how can we enable people, both professional staff and citizens, to be navigated through that system effectively? So in the first instance then, as you can see from this first slide, what we've said is we're going to set about doing that through 2 new integrated community pathways. So in terms of developing integrated teams on a cluster basis to take these pathways forward, if I could just describe them briefly to you. In the first place, urgent community response. So this relates to the different examples here, I suppose, but one would be an individual in the community who's in a non-emergency situation, but their condition is deteriorating quite markedly, but their outcomes that can be maximised through an urgent response through community services, typically in less than 48 hours, and might be immediately in less than 48 hours, so they can be stabilised clinically, and then appropriate care services be wrapped around that. So many examples of urgent response services in the community currently. This is also referred to hospital to home models. Also, stable at home was mentioned earlier in the meeting. The Virgin ACT would be a good example of the sort of urgent response that I mentioned a moment ago. So you can think of this as a reactive model, but where, you know, we heard, didn't we, of the harm that can come to an individual when they're in a hospital environment. That's a bad place to be unless you absolutely need to be there. So where we can avoid conveyance and admission, that's an absolutely good thing for our population. And avoid failure demand as well. The cost of that we see in our system is huge at the moment. So think of urgent community response as our reactive pathway. Alongside that, population health management, which is a programme of work in its own right in its health board. Of course, at the core of that, the opportunity that comes with a new data tool where we've segmented and stratified our population. And that gives us the ability to develop more proactive and preemptive support for people, more bespoke responses. I think also here in terms of this programme, I mentioned the pattern of the construction of multidisciplinary teams on a cluster footprint will be serving both these pathways. So it's important that we do that together. Also with this programme, it enables us to look at the wellbeing services that sometimes we commission, sometimes through the health board, certainly from local authorities, where community development is of course a huge part of what local authorities do, but also looking to partners like housing associations, to the third sector. And again, you know, led by design, can create an effective pattern of wellbeing and community support services that can support proactively our population group. So those are the 2 main pathways that we're seeking to develop. Alongside that, also on the slide, been referenced already this morning to the importance of the clinical navigation hub in supporting our staff to get to the right place within our system, and that's an important and growing influence in our system. Strategic enablers almost looks like a throwaway line at the bottom of the slide. It certainly isn't that. That is absolutely huge. That describes a number of areas. We touched on workforce this morning, so new model of working, which is more integrated, a big step away from perhaps a traditional model, more referral based. So would be a big change for our staff here. Also in terms of the financial envelope here, can we shift to the left by developing these community pathways? Would that give us greater confidence to invest there and invest in value rather than failure, as we're seeing our system currently? One matter that I might pick up quickly for this meeting was I thought it was an excellent development for a meeting that Jonathan and Paul and their peers convened, must have been about a fortnight ago now, where there was an agreement in principle to work towards a regional Section 33 agreement, as it's known. So early scoping work has been commissioned that will need to come back to this group and other statutory partners in due course. But of course, what a Section 33 agreement at a regional level would enable us to do is make joint appointments into integrated teams. It would enable us to pool resources, it would enable us to create a management model around these community pathways that would be more seamless with regard to recourse into statutory structures and hierarchies, where we're able to agree an operational basis for doing that. So really important. Digital as well, of course, is a massive part of this. The ability of our community teams to be able to share information and work across that, absolutely critical. So that's all in the scope of the programme. We could flick to the next slide, please. What I'd like to do here briefly is just show you, so okay, that might all sound okay in terms of setting the scene for this. So how are we moving forward? So if I can speak, well, actually, in terms of both of the pathways, the method that we're adopting is first to really understand what we have. So I mentioned complexity, and it is complex. We have this variation of services currently on the ground. A lot of work being carried out already to map these existing service and management models, because actually we've got different management models in play. Mentioning section 33, with one in place, of course, between Bridgend and the local health board, don't we? So really to understand that, then to develop our sense of what an optimal service model would be in each of these pathways. So I'm facilitating and convening workshops with our staff primarily right now over the spring and the summer to develop that, alongside a sense of what the supporting management model could be. Once we've completed that, we're then in a position to think about transition planning. How do we move from the as-is inheritance to the to-be future model? Really important as we do that, of course, the engagement with our staff and public critical here. I think having some expertise in the room in the first place to develop a good enough first draft, but then to take that into wider engagement, to kind of test that to destruction, I suppose, and build that back up again is actually absolutely what we intend to do. Mentioned on the right-hand side of that slide, then clearly authorisation at all stages through statutory structures, through the regional partnership board as well, because ultimately this means change. This is a change management programme that needs to be worked appropriately through our governance structures. So that's the method we're adopting. A little bit more detail just to show you a glimpse of this on the next slide, please. So I keep speaking of complexity, not to take you through every part of this slide, of course, here, but I think what it does demonstrate, if you just get the sense of the overview, the three right-hand columns are for our three local areas, our three local authority areas, the urgent response services that already exist. So the thing to draw your attention to is just the difference in each of the columns. Sometimes that's, of course, because one of our local authorities came in from a different health board area, but not exclusively so. Incidentally, blue type relates to teams that have some regional integration funding embedded in them. I'll come on to that in a moment. The left-hand side of this slide and the next slide, that starts to sketch out the parts of our future to-be model, which is an outline that's developed through a commissioning group that we pulled together to do that. I think that can be boiled down and simplified still further across the two slides. Perhaps if we can flick to the next one, you'll see that there are 7 main parts, which is a significant simplification of the many teams that you can see described over the right-hand side of the slide. So lots of workshopping to develop that to-be model and then to get into transition planning as we work through the next slide, please, just to give you quickly a sense of the milestones through the current calendar year. I think I've described most of the points here, but you can see them timelined. I'll mention again regional integration funding, really important. That's aligned to these community pathways now as we move forward. We've got an opportunity at the mid-year point to make some changes there too. The other thing, I think I've kind of mentioned most of that in terms of staff and citizen engagement, absolutely critical, and to pick up some conversations with FLICE over the next couple of weeks, hopefully, on how we can plan that out through the next period. So finally then, I think just at this stage, really on the next slide, to ask the board to note the work that's moving forward as it's shaping up. This will return to you as we're in the position to make some decisions here, but we'll be really happy to answer any questions, Jonathan, or indeed to meet with board members individually if there are any particular aspects that they'd like to follow up on after the meeting.
Thank you, Matt. Kath.
Yeah, thank you, Matt, and welcome, and really excited to see this, and fantastic to see the work that started around this really important area. I guess from my point of view, what I was looking for was how we map the pathways of people, they're almost like the patient pathway before you become a patient. So, you know, if you've had a fall, if you've got chest pains, if you've got Parkinson's, what does that actually mean? So when you're developing the community pathways, it would be really good to try and map it from a really person-centered point of view, so that we can, because I think what we need to do more of is engaging with the general public, with their community, so that they can understand our services. As you said, it's really complicated. Trying to navigate our services is difficult, and I just think we sort of need to use, as you say, third sector partners and others to try and communicate and engage more externally.
Absolutely. So part of the workshopping that would be literally the walkthrough that I would facilitate across those pathways. So how do people enter this? What are the referral mechanisms? How does that for them? So there's part of this. One of the projects would be more of a traditional, you know, service specification for the optimal model. This is how the service will be provided. This is the capacity, the access and referral points. But underpinning that needs to be developed actually with a citizen viewpoint in mind. How is that for them when they navigate through the system? So absolutely.
So we can do both, can we?
We
That
absolutely
would be great. Thank you.
And that's the aspect of it. Well, I know Matt is well cited on this, but I know. So Gen, see where we've got a well-developed integrated model there. They've got quite a neat story, haven't they used to describe what it feels like for Mrs. Jones, you know, the generic sort of person. But it's really important, I think, that those sorts of stories are used in the engagement conversations with the population, because we can get wrapped up in describing service specifications and teams, and which is important for us to know about. But for the population at large, if you're to ask people, you know, what are the things, it's, as you said, Kath, it's often in my experience, these things, it's the biggest issue is the navigating between the different bits of the service. And if you can say how what we're going to do will improve that and provide sort of a streamlined, efficient way of people being able to get into the service, that fundamentally for me is a really important thing. So I think you're absolutely right. There's an internal story about how we describe what it looks like from a service perspective, but externally there's an opportunity, I think, for us to have some conversations. There's been lots of work gone on through the RPB already in these sorts of topics, so I don't think we start from scratch by any stretch of the imagination, but it's just how we articulate what we're trying to do in very straightforward terms. You know, this is what it looks like today, and this is what it could look like in the future. And I think actually, you know what, using the story that we heard this morning as this is how it shouldn't be, and you know, and what would we like it to look like, would be a really good way, and frankly, a testament to the individual gentleman concerned, to actually say this was a catalyst for us using real stories and taking the opportunity to describe what we'd like it to look like. And I think those are the things that everyone can relate to. Because a lot of the challenge we have with these sorts of things is, unless you've had direct experience of these things, it's quite, people don't often appreciate just the complexity of it. But I think there's a real opportunity to use stories, and our communication centered around those is a real focus for us moving forward.
Yeah, but thanks, Matt. That was really helpful. I guess a couple of comments and a bit of a plea. So I think, you know, our community services are really complex to navigate, and we have to move that way to a single team looking after a registered population, and we do the internal navigation within that team, not expecting others to have to navigate. So I think, you know, absolutely this shift is completely the right way we need to go. I think the other bit that we need to make sure we fully build into there is the ambition. And I think using stories like we've heard this morning, you know, every day I get a breakdown of all the clinical navigation hub tendencies and the stories linked to all of those patients. And I think what that can drive for us is that level of ambition, because they're sorting out what we've got, but there's also actually making sure what we've got can do more. And do more for our population, and I think that is so important within, you know, this is our chance, isn't it, to make it right for the next however long. And I guess the other bit that sits behind this, and you know, having been involved in these sorts of pieces of work in other organisations, there also needs to be some quite hard stuff in there as well, as so absolutely the team building and all those things, but it has to be underpinned by some really strong expectations and performance metrics, so that we're really clear, because it's all great to come together and do all this lovely stuff, but if it's not having a material impact, then we're not doing the right stuff. And I guess it's just making sure early doors that we've got that focus on that really, you know, some of those hardcore performance metrics that are there to make sure that we are genuinely having a positive impact on our population. But that's great, thank you.
Thanks, Kevin.
With quality statement on frailty, I think is an entry point into that. I guess, and there's some work that we're doing with colleagues to develop that really sharp edge, both operational measures and outcomes for people, a sense of that service shift as well. Can we set ourselves some incentives to manage that through too? So that absolutely, yeah.
Sorry, Linda.
Yeah, just a reflection, really. Thank you. That was really super interesting. But I think it would just be fair to say nobody's cracked this, right? This is exactly the same problem everywhere. But unlike in England, where we are all different providers and trying to navigate through working together with complex financial arrangements, Wales does have a huge advantage in this aspect because this is one health board. So stating the bleeding obvious, I guess, but actually this is something where CTM could really lead the way if we get this right.
Yes, thank you, Linda. Any other questions or comments? Matt, it does strike me as a huge and significant piece or pieces of work that you're now engaged in, and I know you've got a strong working relationship with colleagues in the RPB because of the RPB element, which of course is important in driving and supporting and hopefully delivering at pace some of the things that need to change. But as you rightly said, there's this ambition between the health board and the 3 local authorities to use the section 33 element of the legislation that allows us to pull together that decision making and resource ability to do the sorts of integrated things that we really need to get done quite quickly. Now, obviously that builds on the pathway stuff that you're working on now, which is absolutely the right way of approaching it. And I think reflecting on the conversation earlier, the sort of things that we could do relatively swiftly, I think would be important. But I accept it's quite a large amount of work you've got, so there's quite a lot for you to.
It's a logical progression, though.
There's a logical progression. Yeah, absolutely. Yeah, there is. No, thank you very much. Really good to see you this morning, and I'm sure the board noticed the presentation and report. So thank you very much indeed. We're going to take a 10-minute break now. It's 11:45. If you could return at 5:12, that would be ideal. Thank you very much. And there appear to be some Easter treats outside the gate.
Yeah.
Welcome back. We'll move on to item 5.5. This is the board committee review proposal. And before I ask Gareth to present the report, which is before the board for approval this morning, can I thank all board members for engaging in this quite lengthy and quite detailed piece of work. In my almost 12 months as chair of the board, I've been very keen for us to review the effectiveness of how we operate as a board, and that's involved discussions around how our board agendas are set, what the contribution of our board development sessions is to our strategic thinking and how that work feeds into our board meetings. And as part of that, very crucially, of course, is the important work that the committees of this board undertake on our behalf. Can I also thank Gareth, Callie, Emma and the entire governance team for what has been a huge piece of work. Detailed consideration of some of the challenges, consideration of the opportunities to reform what we do and to improve it, and also a significant period of consultation with all board members. I'm really grateful to all of you for the various conversations we've had about the structure of our committee and where the committees can add most value going forward. There are some proposals in this report for the board to consider today, and I'll hand over to Gareth to lead us through it.
Thank you, John, and thank you for that introduction as well. Yeah, as you say, John, you commissioned this review and this kicked off the start of this calendar year. So everyone who was on the board at that time will be cited on the initial draft proposals. And as John said, a number of you provided some really helpful comments and observations, which, as you now know, John has responded to in full, and that has, I think, improved the latest iteration of this proposal, which is before you today. In addition to engaging with the board, we also engaged with other stakeholders, internal audit, external audit and Welsh Government as well, and equally they provided some helpful thoughts and comments. And in particular, thinking about the Audit Wales structured assessment, which obviously is an annual piece of work the performance audit team does with us. We've taken into account some of the things that we get assessed on for that in trying to formulate the proposals before you today. So, as I said, the document will largely be familiar to you. We've obviously refined and retuned it in line with responses we've had. So, we're looking for the board to consider if you're content that the process has been managed effectively and in line with good governance. And then, as John said, to approve the implementation of a new board committee and subcommittee structure and recognise all the collective responsibilities of board members for this going forward, both for the committees and for things like board development sessions. Should that then be approved, obviously we'll then move to next steps, and with the intention of this going live in the third quarter of this year.
Thank you, Gareth. Okay, there's quite a fair bit of information in front of the board today, including obviously the main report that sets out the consideration of some of the issues, sets out a proposed new framework where this board would move to a 7 committee number compared to 9, which is what we currently have at the moment. But there would be quite a fundamental shift in addition to the 5 statutory and mandatory committees. There would be 2 additional committees, one strategic development and the other on operational delivery. There would be recommended 3 formal subcommittees of the board as well, which would be the Health, Safety and Fire Subcommittee, the Organ Retention Subcommittee and the Power of Discharge Committee. So fundamentally what the shift means is a reduction in the number of committees. In the way that this has been set out, the attempt is still to ensure that those strategic matters that are currently considered by our committees will be considered by the new committees, I have to say, I also think there are some things that are sometimes discussed in committee that ought to be elevated to the board. And Paul, Stuart and I will be having a conversation over the next couple of weeks about those areas, for example, of digital innovation, because digital innovation is a key enabler. Strategically, it is of huge value to us as a board. And there are those matters that perhaps traditionally may have been discussed by the Digital and Data Committee, but I think needs to be elevated to this board because of the significance of what that will do for transforming our health services over the next 5 to 10 years plus. I mean, there's some things that are very immediate, as we know. So, so this isn't just about what gets shifted between sort of one committee and another. It is also about, are there those things that we also need to be focusing on as a board and to bring those to life in these public board sessions. So there's a lot of information in front of you. There's that key proposal in terms of that recommendation. Any questions to me or to Gareth in terms of the work that's been done, or any observations that the colleagues wish to make? Ian and then Karen. Thank you.
Yeah, and as people know, I was concerned about this at the beginning. I'm not so concerned now, but I do still have a little few reservations, which I'll elaborate on. I'll talk specifically about digital and data. You mentioned digital and data, but some of these concerns extend to some of the other committees as well. Not opposed to the number of committees going down, and I can see the rationale for doing it. It reduces the amount of work of the board, and it makes perfect sense to me from that point of view. What I'm a little concerned about, and I can't see a mechanism for doing it at the moment in the proposal, is how we capture some of these areas. Let's say digital and data again. How do we capture that so to make sure that it gets its hearing, if you like, in the new committees? The mechanism for capturing specific areas. You could say the same for population health as well. What's the mechanism for making sure we capture these areas from committees that previously existed, and maybe something on that, a statement on that maybe would help in that area. Specifically on digital and data, I never saw that as a permanent committee anyway, in my own mind. I think it's about digital maturity in an organisation. Certainly we weren't at the stage of digital maturity when that committee was created. I don't think we've got there yet. We've made a huge progress in that direction. I suppose my concern was, is it a little premature? Don't know the answer to that. I don't oppose getting rid of it, but how do we still capture digital and data? And I'll be going in a year. When you have a new IM, I think it would be important to have an IM that focuses and still focuses on digital and data, even if you're a committee on that, just to keep that focus from the IM's point of view within the discussions.
On that point, I absolutely agree with you. I think having somebody with that background, that skill set, that understanding as to what is currently working out there and what the future potentially is looking like, I think is really important to the work of this board. Just to reassure you, in terms of how things are captured in those committees, the people in the driving seat will be the chairs and vice chairs of those committees. So the agenda setting for those committee meetings will be absolutely critical in making sure that there are those standard items and those things that are covered off in a way that's thoughtful. And I remember, and I've had some of the conversations, for example, with Dennis around people and culture, making sure that things aren't lost just because we go to a new system. And I know in previous committees, there were examples of where perhaps items were right at the end of the committee agenda and literally where people were exhausted, allocated a few minutes, and that was it, done and dusted. And that, this comes down to IMs who are leading these committees to really drive that agenda and making sure, therefore, that those key elements are captured in those committee considerations. Dom?
It does give us an opportunity, I suppose, instead of it's digital, all right, we'll take that to the digital committee and everything there gets put into one committee. It does mean we have to think about what the digital impact is and quality and safety in people's impacts. It makes us actually make it part of everyday, what we always do. And instead of it being Stu and his team just lives digital, we all have to deliver digital. So I suppose that's the opportunity it gives us, I suppose, from doing it like that. So as long as we make sure it's put in the committee.
I'll bring Caroline at this point, and I'll come to Stuart in a moment and then to Kath. Can I just make one other point to Ian, which is, I suppose, in terms of not knowing exactly how this will work, although a lot of work has been done setting out what the model agendas could look like, work has been done around potentially, I suppose, what membership of committees could look like, subject to people's views. I'm absolutely committed to reviewing this in 12 months' time, or reviewing it as we go along, and then 12 months from now saying, has this new system worked for us? Because there may well be over the next 12 months we say, actually, this hasn't quite worked in the way that we thought, or this has worked really well, or actually the whole thing's disastrous and we need to revert to type. But I think having that openness, I think, is really important. So hopefully this will work. I think a lot of work has been done to plan for this, but we will review it over the next 12 months before coming to.
Totally support that. Makes sense for them.
Thanks, yeah, much appreciated. Karen.
Yeah, a couple of brief comments. So I think this is a really detailed piece of work and I really welcome it and I support it. But my concerns are, I think when you talk about digital and data in particular being an enabler, well, I think lots of things are enablers. Finance is an enabler, infection control, estates, they're all enablers. And I think it's a real challenge to us as to how we make sure those things get the appropriate scrutiny at the appropriate committee. And I accept that the agenda setting is really, really important. I think there's more we could do as a group. I would certainly welcome some more development in terms of how that we could do together, in terms of how are we doing the agenda setting, how are we checking ourselves that what we're discussing is strategic, how are we deciding what goes up to board. And I know you can't teach, I know that comes with experience, but I think if you're chairing a committee, you don't necessarily get a sense of how everybody else is doing it. And I presume the team would say if they thought you were an outlier, and the execs obviously have great input because presumably you'll be the ones that think, hang on, I'm giving this presentation at 3 different committees here, and there's a really big role then for you to say, well, that's absolutely not appropriate, and then the judgment about what comes to board. So I support it. I'm a bit concerned that some of the committees will be very overloaded, but we won't know that till we do it. And I also think there's scope for development to make sure that we are being consistent in terms of what we keeping the conversation strategic and what we escalate to board level. So I think there's more work to do, and I really welcome the fact we can review as we go along.
I don't disagree with that, Karen, and thank you very much. Patsy, you have had your hand up for a while. Sorry, I know you quit querying whether it is working, so that was my fault. Apologies. I'll come to you now.
Okay.
Kath.
Sorry, I didn't see it was working. Yeah, I support this as a process. Agree with what Carolyn said about overloading agendas, and we won't know. But we do need to be led by risk in the strategic environment. So our BAF and which is sort of part of our risk register, should help to inform the agendas both for committees and board. And then just a final point is that remember that we need meeting dates that allow for the very latest information. So papers are ready as information is available. So finance close down performance information. If we're only meeting 4 years, it's important that we get the very best and the latest information that is available.
Thank you, Patsy.
Yeah, just a couple of points to perhaps bring some life to Ian and Carolyn's comments as well. So totally agree with you, Ian, in terms of that digital independent member role, and actually we've seen over the last 6 months with Carolyn and Linda as well, they did kind of constructive, supportive criticism, challenge, not criticism, but it's been really constructive. In all seriousness, it's been really good for the last 6 months in that sense. From my perspective, and you are right, but I've been in other organisations where we've done this actually, and it can work. Getting the agenda right is key. Patsy's absolutely right in terms of focus on the risk. From an operational perspective, we will have, things that we'll have to do anyway in terms of our action plans for information governance and cyber. So they have to be part of that agenda anyway. And then the last bit I was going to say, and actually if I reflect on the board development session we've recently had together, which I thought was excellent, how we use board development sessions going forward as well, I think is really important. The digital element is going to be so intrinsically linked to our strategy. So, you're not going to be able to get away from it, if you like, in that way. So I'm pretty confident that we will have a focus on it.
Yeah, good question. Kath.
Yeah, I thought it was a very detailed piece of work, and thank you very much to Gareth and Carrie and the team around doing it. I totally agree that we need to keep looking at it, see how is it working or not. I also agree that that particularly 3 of the committees particularly are going to be pretty quite heavy committees, and I think it's not just the agenda setting, it's also I think the board members and the exec team in terms of what they're doing with those committees, making sure we're not getting too operational, we're keeping the focus, as Patsy says, on the risks and the back, and keeping it strategic. So I do think it's around the exec team as well, thinking about what should go up to committee and what shouldn't. Do you know what I mean? And what sits with exec team and underneath exec team. So, for example, you could have, using digital and data, as we're talking about that, you know, a forum with, you know, around digital and data that sits within the, you know, beneath the exec team, or I don't know, you know, rather than it having to be a formal committee. And obviously, digital and data is absolutely in the strategic committee and the operational delivery committee, because what we're moving towards trying to look at is where are we currently and how are we doing, you know, in the next 18 months, and then also longer term, so that we can make sure we don't lose sight of that longer term. Because of the nature of us, we're all pedaling very hard, aren't we, to try and make changes now, but we've also got to be obviously keeping that view on the longer term. So yeah, I really endorse the work that's gone on, but I do also agree that we need to keep a really close eye on it and feedback as a whole board as well to see how is it working. Thank you.
Yeah, thanks for everyone's comments. Really welcome. It's all really constructive stuff. And just to speak to your concerns, Ian, absolutely. You know, if this does get approved now, there'll be a lot of work between now and the new structure going live. So we'll be doing a lot of work with obviously the existing committees, which might no longer be there going forward, in terms of that transitional arrangement, legacy reports, and making sure that we don't miss anything. Going forward, yes, absolutely, the planning session, agenda planning sessions would be absolutely pivotal. And as everyone said, we've all got a collective role and responsibility in that, and ensuring things are brought to the meeting which need to be aired. I also agree with Patsy's point around using the BAF really as a tool. It's not just something we talk about at board, it's actually something we use actively in terms of determining what are the substance of the things which get discussed at our committees. I think that's a really useful way of using that as a live, not just something that we talk about. And I also recognise the points made by Carolyn and by Stuart as well about board development. I think the way that it's alluded to in the paper as well, the way that we use board development in the future, we need to think about how we develop skills, how we work as a team, and all those kinds of things as part of our board development programme, but also not lose the kind of the information we need to glean as a board through board briefing sessions as well, and maybe repurposing some of the catch-ups that we have for things like that as well. So I think that's all part of the package, and obviously, as John says, we welcome any real-time feedback anyone may have, and certainly build in, you know, a number of good points over the next 12 months and keep the conversation going really if this does get approved. So thank you all for your comments.
Thank you. Any other comments or questions? Okay, I'm sorry, Ian, yeah.
Yeah, just to come back to say, yeah, I fully accept all the points that have been made, and I 100% go along with this. That's not the monitoring, I think, is a really good idea as well. So yeah, I'm just putting my concerns there.
No, that's absolutely right, and I'm pleased you've got it for the public record.
Yeah.
Like, you know, making sure we get this right is important, and you know that it is a significant change, and we do need to ensure that the workload is appropriate, that things go to the right committee. And that both the exec and IMs are engaged in that conversation as well, so that we can make sure that we're all on the same page. So the recommendation of the boards are to consider that the proposals be managed in a manner that demonstrates good governance and provides assurance that the implementation will be managed effectively and efficiently. I think, you know, that assurance has been given because of the level of detailed work that's been undertaken. The board is being asked to approve the implementation of a new board committee and subcommittee structure that's set out in section 9 of the report. The responsibility of all board members in terms of the approach to board development sessions, as Gareth said, board briefings and agenda planning, which will be fundamentally important to how well the committees operate, because you will be in the driving seat. It does come down to you as to what appears on those agendas, and to approve the next steps as outlined in section 23. So just to be clear, if the board approves this today, further work will be done around the terms of reference and operating arrangements for the new structure, and they will come to a public board meeting by the end of September. So we are by no means rushing this. It's being done in a very planned way, and the intention is that the new structure would be implemented by Q3 of the 2024-25 financial year, so effectively by January of next year, which feels like a long way away, but rest assured it isn't. So a lot of work to be done, but obviously to make sure that we get this right when it's implemented. Are colleagues happy to approve the recommendation that's in front of them this afternoon? Yes. Okay, are there any objections? Just important to ask. No. Okay, thank you very much indeed. Item 5.6, the establishment of the NHS Wales Joint Commissioning Committee as a joint committee of the 7 statutory health boards in Wales. There are a raft of documents in front of you this afternoon, and I'll invite Gareth to present the report, which is before you for approval. Thank you.
Thank you, Chair. And I think Paul's already set the scene in terms of a lot of the background and context around this in his Chief Executive report earlier in the meeting. So I won't repeat things which Paul has said before. But before you today, there are a number of recommendations, as John said, and a number of suite of governance documents as well, which are before you this morning. In terms of the recommendations, I'll obviously pull out in particular recommendations D and E. D is around the board adopting the amended standing orders, which were issued by the Minister on the 18th of March this year. And in the correspondence from the Minister, you will note that there is a Welsh Health Circular to follow that. We haven't received that as yet, but that will follow. And obviously, as and when we do receive that, we will update you all. But we're looking to adopt those amended model standing orders. And obviously, recommendation E is around adopting the statutory financial instruments, which were issued by the Minister on the 19th of March of this year as well. So there are a number of things to note, but those are the 2 things that we're looking for the board to adopt this morning. In addition to what's in the paper, obviously, as Paul alluded to as well, as a health board, we are responsible for hosting the new joint commissioning committee. And as Patsy mentioned in a highlight report, we had a really detailed discussion with the programme director from Welsh Government on what this may mean for Cwmddarth Morgannwg going forward in terms of our hosting arrangements. I just want to reassure the board that we are in the final stages really of just ironing out some of the finer detail around how the accountability arrangements in respect of hosting will work going forward in terms of agreeing our position with that Welsh Government. And I hope that that will be completed in April. And again, very happy to confirm with you when that is done. So I just thought, given we are obviously part of the joint committee, is one of the 7 health boards is obviously what the focus is on today, but obviously there is a specific responsibility of us as hosts in respect of that. So I thought it's best to give you a brief update on that. But as I said, just to reassure the board and the Audit and Risk Committee, we'll keep you fully apprised of that and let you know once that has been ironed out and finalised. But for today, our responsibility is to obviously look at the recommendations in the report, and in particular, as I said, recommendation D and E in adopting the standing orders and the SFIs.
Thank you, Gareth. It's quite a comprehensive package of information in front of the board today. As Gareth said, there are, I suppose, from our perspective, there's that dual approach. The first is as a health board, we're being directed to approve the new arrangements for the Joint Commissioning Committee. But there is the second matter which we are still working through with Welsh Government, which is the I suppose the interface between the individual who will be leading the Joint Committee as the Chief Commissioner, but also that person having that accountable officer status, which has now been determined by Welsh Government. So trying to ensure that the appropriate governance is in place to respond to that, because we have a duty as the host body, and as this board, we have to ensure that our governance arrangements are robust for what is a departure from what we've been used to in the past. So I will obviously keep the board up to date as to what emerges from those discussions on that element, but specifically on the element of being asked to approve the suite of documents in front of us this afternoon. Any questions or comments on the establishment of the JCC itself? No? Okay. Sorry, Patsy.
Yeah, just a quick one. paragraph 3.12, it talks about the memorandum of agreement between the health boards. Is there a draft version of this, and are we assured that it will reflect everything else in the paper that we're presented with and being asked to approve today?
So can I take that, please? Yeah, so that hasn't been drafted as yet, but that is part of one of the outputs coming from the governance work stream. So my colleague Rami and I will be finalising that during April. But obviously, in drafting that, we will of course assure it's properly aligned with suite of documents as approved. So it's not ready yet, Patsy, but I can give you the assurance it will be fully aligned with the governance suite of documents before you today.
Thanks, Karen.
Thank you, Patsy. Kath?
Yeah, just a question around how we show this in our board assurance framework or our risk registers, because obviously it's a new body, we're in transition, there's still some unanswered questions, you know, as you've said. So how will we?
So that's something we will give active consideration to now as the committee goes live, and I guess we've got that two-dimensional thing in terms of our hosting arrangements as well. So that's something I'll look at between now and the next board.
Thank you very much.
Thank you, Beth. Okay, any other questions or comments in respect to this item? Okay, the board is being asked to adopt the amendments to model standing orders and reservation delegation of powers for local health boards. It's being asked to adopt the standing orders for NHS Wales Joint Commissioning Committee. It's being asked to approve the scheme of delegation and reservation of powers for NHS Wales Joint Commissioning Committee and the standing financial instructions for the NHS Wales Joint Commissioning Committee. Can I ask if colleagues are content to approve those matters before us this afternoon? Yes, thank you very much. In respect of the work that's been ongoing around the interface agreement and the memorandum on the accounting officer responsibilities, we will keep the board appraised as to that, because that is important in terms of how we as an organisation function as the host body. So we will keep the board updated. Thank you very much. Okay, we'll move on to item 6, which is delivering our plan. Part 1 of the session on our performance dashboard, and as usual, I'll pass to Linda first to lead the item. Thank you, Linda.
Thank you, Chair. So just two things to say about the nature of the report. One is that I took a bit of a liberty on page 4 of the report, the bottom left hand corner, which is our operational performance. The bottom 2 there, you'll see that one of them's the number of patients waiting more than 2 years for referral to treatment. There's nearly 3,000 of them, and it's actually deteriorated by 11. And when I first got a version of that report, that was shown as a red arrow going down, and I negotiated a little bit of tolerance to call it more or less the same. And ditto with cancer performance, that's gone down by 0.2%, which with normal variation doesn't feel like we should keep flipping the arrows up and down, but I need to bring that to your attention because you know, it'd be unfair to do that without making that clear. So we're wondering about a tolerance that we apply here of proportionate to the actual numbers, but in the region of about 0.5% either way. We call that. Otherwise, it just looks crazy. You can't really get anything from, you know, looking from one report to the next in terms of what's really happening. So I take it people are sort of comfortable with that. Thank you. And the other is that we keep talking about how we improve this one sheet in terms of that overall indicator of you know, the kind of health of the organisation, and we've actually drafted in some support from CTM, and we've got some more discussion with that individual back at exec not next week, but the week after, I think. So we're making some progress on that. You'll remember that this version is the best we could do with the metrics we've got, whereas we're trying to see if we could move it into metrics we don't have but could get, that give us more intelligence. Apart from that, Chair, I'll hand over to and I can never remember who's
Yeah.
first. Thank you.
Thank you, guys.
Thank you, Linda.
Thank you, Mr. Prosser. So I rather than go through the performance dashboard, I was actually going to do a little bit of a deep dive into unscheduled care flow within the health board. Very conscious, we heard from Adam this morning. We've talked a lot, a variety of subcommittees and at this board around the impact of emergency flow on the ability to deliver the level of operational performance that we, but equally and probably far more importantly relating to the quality and safety impacts of what our patients experience. And we know very clearly that our emergency departments are crowded, and we know that means it is difficult to hand over our ambulances in a timely way, which creates a level of risk within our community. But we also know that the impact of that crowded ED is far more significant than a percentage point on a performance chart. Because we have patients waiting in our communities, but also we have patients who are waiting for a long time in our emergency departments. And there is very clear evidence that a prolonged stay within an emergency department does have an impact on in-hospital mortality, but as we've also heard, has a real impact in terms of key quality metrics such as pressure damage, such as infection control, and also, and we discuss this a lot around our stroke performance, that it means that patients aren't getting to the right MDT that they need to as part of their care. So so I guess the important question is, so what's the data beginning to tell us? And if you look at this slide, so just in terms of some of the data, I'm using 2019-20 as our baseline. We know that 2021 and 21-22 could be a little bit odd because of the impacts of the COVID pandemic, but looking at what's happening within our hospitals. And the first startling piece, I guess, for all of us would be that the number of patients attending our emergency departments in 23-24 is lower than we experienced in 2019-20, and that's a little bit of an anomaly. If you look at what's going on across the rest of the UK, and it is 10,000 attendances lower. The other key aspect on that left of the chart for me is that the volume of our attendances who come by ambulance has fallen significantly, and that's equating to around 30 ambulances fewer a day hitting the forecourts of our emergency departments. What we also can see is, whilst the number of people coming has dropped, the number of people who are waiting for more than 12 hours within our emergency department has gone up. And that's a real concern. So 20,000 patients in 23-24, that's double what it was in 2019-20, experienced a wait within our emergency departments of more than 12 hours. And the that's grown within those that are admitted, but equally those that are not admitted has gone up exponentially. And if you look to the right of the chart, then who's been admitted to hospital, that number has gone down. And even if you take into account the growth in the over 12 hours who are subsequently discharged, a proportion of those probably would have been admitted had a bed been available for them. Even if we assume that cohort was added to that, the level of admission to our hospitals is lower than in 2019 and 2020. So what the majority of those metrics are telling us is that actually this isn't a demand-driven pressure. That the patients hitting our front door, it is the challenges we're experiencing are not being driven by by an increase in attendances and admissions into our hospitals. If you go to the next slide, please, Kat. But what we can also see on this chart is that if you look at the acute hospitals, so that's the top right hand set of boxes, whilst we're admitting fewer people, we're using significantly more beds to deliver that care. So we used 322,000 bed days in 2019-20 to deliver that level of activity. And in 2023-24, that figure had gone up to 353,000. Now that's the equivalent of 88 more beds being used to do a lower level of activity. So we know that this isn't about we're using more beds to do fewer. So a big assumption at this point is that patients are staying longer. And yes, our average length of stay has gone up by 1.5 days compared to 2019-20. If you look at the community hospitals, and just to note that in the blue bar for community hospitals, that would have included the community ward at My Stay Hospital, but isn't in the red box, which is why there is a slight drop in the number of occupied bed days. The stark position here is the impact that we've now seen in the length of stay of the patients in our community hospitals. So they are staying with us now on average 10 days longer than they were in 2019-20. I think it's worth just making board aware that for most rehab pathways, you would be looking at a target length of stay for patients on a rehab pathway of around 28 days. In terms of making sure those patients are clinically optimized from a rehabilitation perspective. And we're running at over double that length of stay. And so we know that begins to have an impact on outflow from our acute hospitals into our community sites. And we're probably in the region talking of the impact of that being 400 to 500 patients fewer each year being able to access rehabilitation pathways in a timely way. So we often talk about stroke and the impact on stroke. We know there are times when the stroke unit at Prince Charles is probably 80 to 90% full of patients who are clinically optimized from an acute stroke position, but are unable to transfer down to the stroke rehab unit at Ysbyty Cymronda because there are delays in getting those patients out. And you can see that, and that actually happens not just in stroke, but across all our pathways of care. If you could dip to the next slide, please, Kath. So whilst the overall bed day number has increased, we also know that we're managing a greater number of patients on a 0-day pathway. That number, that's on the right hand side, that purple box is slightly higher than the pre-COVID volumes. We've recovered from challenges in that COVID period and stepped that back up, and we know that we are bringing on more and more same-day emergency care services that allow us to treat some of these patients on a 0-day length of stay basis, and can turn them around with other community or acute return inputs. So it is important that we recognise. So it comes back to this challenge of we're admitting fewer, we're using significantly more beds, and as part of those who we're admitting fewer, we're actually treating more and more of those on a same-day basis. And when if you were to look at the over 29-day cohort, that number has gone up. So what we're seeing is an increase in patients who are staying for a significantly longer stay within the acute sector, and it is rare for an acute admitted patient clinically to require to be in hospital for that length of time. So in terms of the general population. Next slide, please, Kath. And then this chart then draws out what's happening with discharges and average length of stay within our community hospitals. And what you can see is the volume of discharges has dropped, and it's dropped by by around 25 to 30 patients a week, and that length of stay you can see going up. And so part of the challenge here is when what we want to see for good performance is the green line sitting below the blue block. When it goes the other way, that's suggesting we've got a challenge, and I think we all know that we've got a significant challenge in how our community hospitals are able to move patients through. If you could go to the next slide, please. Thanks. So what's driving these patients staying longer? So as members of the board will be aware, we introduced the electronic whiteboards, and they've been an exceptional success, and now allow us to really capture live the status of every patient, where they are in terms of their pathways, and how we can move these patients through. So if you look, sorry, it's quite a busy slide and lots of lovely coloured lines, but we'll worry about the top four to begin with. So they are the main contributors to the challenge. The top dotted line, and I think this is really important when we consider the story we heard at the start of the board, they are patients waiting assessment. And as you can see, we are running with between 120 and 160 patients normally within our beds waiting assessment. And we heard from Adam how long that process can take, and therefore the volume of bed days that is occupying. If we then look at the next line, which is the sort of slightly dotted, sorry, no, go back, please. Lovely, thank you. The green line, that is the cohort of patients who are waiting the start of a package of care. So again, a significant proportion of patients sitting across our beds who are waiting for that package of care to start. The blue dotted line is those patients that are waiting a placement, so a nursing or residential home placement, and then the red solid line are those patients waiting to move from an acute bed into a community hospital bed. If you look at those as the top four cohort, that is averaging between 280 and 300. So that's 280 or 300 people who we heard the story of this morning. Now, many of those patients we do get home, and that's really important to note. But there is a real challenge here, which is our bed day consumption is very, very high. And the other bit that's important to draw out is we know that both the physical impact and the emotional and mental health impact of being in hospital for a prolonged period of time when you don't need to be there is significant. And again, we heard that very clearly through Adam's story today. Next slide, please, Kat. This is then just drawing that data out specifically for the community hospitals. So, we had around 40 patients on average waiting for transfer to one of our community hospitals. And as you can see there's probably about 90 to 100 patients waiting for onward transfer from those. And these are patients that we want to get down for rehabilitation, for reablement, and to support their recovery. And they're spending prolonged periods of time on the acute wards, which aren't necessarily set up in that same way. Next slide, please, Kat. And this bit I think is really, really important, and it speaks to the talk that Adam gave earlier, but equally links to what Matt was talking about in his slides, which is understanding then what's the impact of the comorbidities of the patients that we are serving. And often we look at age, and that a patient who is over 75 is normally going to have a longer length of stay than a 35-year-old who's being admitted. But I think what this data is really, really powerful in setting out is that there are a handful of clinical comorbidities where we know will have a very significant impact on their length of stay. And actually, we need to think really differently about how we support and manage those patients. And dementia, as you will see, is a key influence. So if you look at what the average length of stay for all conditions would be for a patient without dementia, it's around 5 days. If you have those same conditions with a dementia, you are probably going to be in one of our beds on average for 30 days. And that tells us that there is something really differently we need to think about in terms of managing patients in the community. What are the advanced care plans? How are we supporting that? Because for many of these patients, it's around a crisis and a change in their care requirements. And that is something that is predictable. We know with patients with the dementia, they're going to deteriorate, their needs will increase. And there is part of what we need to be ensuring is that we're managing that proactively community and not having a small trigger creating then a real challenge, because being in an acute hospital with a dementia is probably one of the worst things we can do to a patient. And it's so really, particularly if they don't have an acute medical need to be there. And so it's vitally important that we look at and use this data to drive how those community teams function, and that in terms of the capacity we've got, we can drive that through. Next slide, please, Kath. Again, this is about looking again more broadly at what those comorbidities and risk stratification has done in terms of length of stay. And you know, it just reinforces that there are a cohort of patients that we need to support, cohort of our population who we need to do something differently with, who we can help, and ensure that when they do need an acute hospital admission, we can manage it in a very different way. Next slide, please, Kath. So I guess to conclude, you know, this was about sharing some of the data and understanding what it looks like, rather than being clear these are the specific actions that we're going to take. But I think there are 3 key themes. The first is we need to continue to reduce unnecessary conveyance and attendance. We've got really good input and activity going through the clinical navigation hub. That is having a material impact on patients for whom an acute hospital attendance from a care home setting would be the wrong thing. They're working very closely with the ambulance service, where they don't believe a patient needs conveyance, but they need support to make that decision. And it is about how we grow that service, make that service more functional. And how it links in with, as Matt described earlier, that single emergency community pathway. Because lots and lots, we've added an OT to that cohort, into that staffing group within the navigation hub, and it's had a massive impact, positive impact, in terms of supporting people to stay in their own homes. We also know there's further opportunity to increase that 0-day length of stay cohort, because we are increasing our ambulatory capacity. We will be opening the SDEC facility at Prince Charles, same-day emergency care facility now in the course of the next month. And there is far more work that we can do to further support patients on a non-inpatient basis. But the big thing, and you know, the data tells us that where the biggest impact we can have is around the back door, and how we reduce the length of stay of those patients who are waiting. And Paul touched on earlier on discharge, you know, the trusted assessor model. What we need to think really differently about is what is our integrated discharge and reablement service and model between us as the health board and with our colleagues in the local authority, because that's where these patients need to be being supported. You know, we have patients that are deconditioning. We have patients who are coming to harm through infection and other things, where we could actually be supporting them far more effectively in their own homes. We're opening more and more beds. You know, as Quality and Safety Committee members will be aware, you know, we end up boarding patients, we end up putting patients into inappropriate surge areas. That impacts then on our elective performance, and so we've got to cut into this in a different way, and it has to be a different approach to support our population to stay as well as we can get them and support them home as quickly as we can, rather than keeping them in an acute hospital. I'll stop there, Chair.
Thank you. Thank you, Gethin. I won't take questions yet on the slides because I'm conscious that we'll come back to it, but I'm conscious that other exec colleagues need to provide an update on their areas as well. However, Dom, I'll come to you next, and then Greg, I'll come to you on the quality aspect of the report.
See if I can segue the two together. I mean, we can get this right to say what we need to do here. I think this is really where all your commenting on that, having a focused team that starts looking at this tells us, we know where to start from. And dementia is a huge issue. We know that. And I think, Matt, you mentioned it earlier on in your reports, one of the things we've looked at what's patchy, is what the availability in the community is, and it's how we can improve that community dementia care to enable us to get patients home because there's a proper support there. And if there's one thing that we can start to dial down on here at local state, probably that's where we need to put our sort of but it's incredibly useful having that data to know where we need to target our resources now. So thanks, Gav. The other thing I would like to look at is, this does lead me into the mortality data, is we can actually use dementia is a part two. So whenever someone dies with dementia, it's recorded on the death certificate. So we can start looking at actually how many deaths, how many cases have you actually seen, like this morning, are in reality happening in each of our hospitals, which is something we have to know and what we have to be able to address by knowing that data there. So just a very quick update, I'm going to mention my report later on, is the only thing I was going to say was about mortality. So, that we have actually started now, the process is in place for our new way of collecting our mortality data. We're going through this month, we're doing it as a bit of a trial run, we're adapting things. But this is a real success. This is not something that's come to the digital committee as we run, but it's been in conjunction with Stuart's team, my team, and with the bereavement teams across there, of how we go about and actually getting real data every day. So the go live is officially the 1st of April, but we're having a month of trying it, and actually we're getting some really good data already. But I don't want to bring you any data in the next 3 months because it's going to be so small numbers. It's going to be really obvious if we bring it to a board meeting, you can identify if their loved ones are on there as well. So I think I need to leave at least 3 months and I bring you some data, so it's a little bit more anonymous. But good progress on there as well. I just wanted to let you know.
That's fantastic. Great.
Yeah, and we do have a dementia listening and learning story coming to the main board, so it's good that we've got that connectivity now. I guess from my section of the report, from a PTR perspective, by exception only, we still remain challenged with our backlog of our NRI, so our serious incidents. It is coming down slowly, but not quick enough. All of these cases have had a rapid review, and family members are involved if they choose to be, and all family members are allocated family liaison officers, because it's clearly not great either being part of an incident or as a family member waiting for an outcome. So we maintain that communication with our families. We do have a trajectory now in place to reduce the backlog. I think we just need a bit of a renewed focus now. We've gone in, we've appointed into some of the leadership roles in the new care group, so we can get some traction behind that. Good news from a gram-negative bacteremia perspective. I brought to this board previously my concerns around E. coli infections. They have started to level off, which is great, and in fact better than last year's performance. And I think that's largely related to some of the work around inpatient catheter care. And finally, and Gethin's just mentioned it, I still remain very concerned around our patients that are boarding. Colleagues know Friday's my clinical day where I'm out and about across the sites. We do have risk assessments in place to place these patients in these uncommissioned areas. So just to give a bit of reassurance to the board around that, although dignity and experience of care is definitely compromised when you're that 7th patient in a bay of 6 patients. Yeah. And it's clearly been amplified by Adam's story this morning. So as part of the senior nurse checklist every day, they do make contact with those patients every day now, ensuring that the risk assessments are kept updated. But sometimes we're doubly and triply boarding on wards, particularly in PCH. So clearly that adds more pressure to the staff as well, that have more patients to look after, and our patients clearly have a high acuity generally. So yeah, that's still probably one of my biggest concerns. But obviously we've heard lots of good things from Gethin today in relation to now us seeing the data and properly starting to understand it and action. And that was it from me. Thank you very much, Chair.
Thank you. And Helen, I'll come to you on the people aspect of things. Thank you, Commissioner.
No, thank you very much. I think looking at the metrics that are reported in the pack, we can see good levels of performance and an improvement trend across all of our metrics. Our sickness continues to come down, and we're seeing it at the levels that we were at pre-COVID. While our turnover rate, isn't where we would want it to be, it is actually still coming down and reflecting a lot of the work that's happening across the organisation. Significant improvement around our agency spend, and PADR and core learning both are at good levels. We dipped very slightly in the last quarter, but at a trend that is now reflecting where we were pre-pandemic. So I think the metrics really represent, I guess, the good work that's happening across the organisation from all our managers, and we do get a good opportunity at People and Culture to go into those in more detail as well.
Thank you, Helen. Much appreciated. Okay, colleagues, we've got the dashboard in front of us. We've had a set of slides as well from Gethin, which really do add to the discussion we were having earlier as well with Adam and with Matt around the scale of some of the challenges. Questions to any member of the exec on the dashboard? Carolyn, and then Geraint, you had a hand up earlier, didn't you?
I did, but if you want to save time, I'm quite happy.
No, certainly not. No, I'm not. We're not going to push. Sorry, Carolyn.
Yeah, just very quickly, I just think that issue of forwarding, we've got lots of detail now. That's been really helpful, Gethin. And so we've got lots of information about what causes it all, and we know that. And I think going back to Paul's suggestion about something coming back to this committee in May about what are we going to do about it, I think we should make sure forwarding is part of that. Because what worries me is, and I know everybody knows it, is it just becomes normal practice. So what level of authority is needed to put people in a forwarding position? You're almost disguising a problem, aren't you, by just saying, well, that's what we do as a normal practice now. It's become normal, and it's not great for patients. And I just think we need to resist at all costs it becoming normal. So I think that should be included as part of our plan, but also what level of approval is needed? What's the process? Who decides?
It's the director of nursing for the care groups to board, and then if we go over that, it's one of the execs.
And obviously you're doing that on a risk-based approach, which I completely understand, but I just worry that it is becoming normal practice.
I agree with you, Karen. I will also say, and I'm going to be a bit contentious here, but we have been given pretty clear directions sometimes by Welsh Government colleagues saying you need to offload ambulances at all costs. And frankly, if that means boarding patients, do it. So, I mean, I'm not being funny, but, there's got to be some ownership here of this problem nationally as well, because we're getting instructions.
Well, it's being made to be our problem, isn't it?
Well, and as it constantly says, it's about transferring risk from one bit of the system to another bit of the system. And the idea that a patient is less risk because they're boarded on a ward than a patient sat in an ambulance or a patient sat in a corridor in ED, as we've heard today, is a complete fallacy. But there is a lot of pressure around the ambulance handover metric, which leads to then people saying, well, just sort it out internally and just, basically find space to put these people. But as we all know, as a walk around stuff, you see the conditions in which we're having to deal with patients, where we're having to hold people in facilities that are not good. It's just not acceptable. So you're right. We've had some conversations about this with the execs about how the process is managed, and we've got a clear escalation process now as to how it is managed. But I'd also remind us, well, not that long ago, also we had an HIW report saying we shouldn't be boarding in corridors at PCH. So again, so somebody's telling us not to board in the ambulance, another person's telling us not to board in the ED. Where do these people end up being? They all end up being held in a ward in an inappropriate space. And so, this is an endemic systemic problem. Not saying it's not surmountable, but we've got to find ways to manage this situation in a better way, because as I said earlier, we are spending money anyway on these people, but we're spending money on the wrong thing.
Geraint?
Yeah, I just wanted to go back to Gethin's rather vexing graph that you had on earlier. Again, touching back on the assessments, and there seemed to be a remarkable jump very quickly in just the speed of 24 hours.
Yeah, that was the rollout of e-whiteboards. So one of the issues was we had no way of capturing that data historically. And so when the e-whiteboards went live,
Okay.
then we've been able to we capture that data now on a daily basis. Previously, before e-whiteboards, it was done once a week.
So you're saying that it would have, those figures would have been as high as they were if whiteboards had been come in earlier?
We don't. So the anecdotal evidence is that and if you look at the data we had from the spot checks, those numbers weren't as high. So the feeling is that it's a deteriorating position, but we don't have the data to go back and ascertain whether it is or not. So what we've got is going forward.
Presumably you were in Go Command at that time, yes? So
No.
were you in Go Command then?
No.
But what we probably need to do on the graph is just annotate that actually the data was collected. It wasn't captured electronically prior to that date. Because rather than think we got from 0 to it's based on a week.
Apologies. I've got a list of colleagues to get through. Linda, you're on my list, don't worry. Ian, I'll come to you next. Thank you.
Yeah, it was great what Gethin gave earlier. It explained a lot of things to me, I think. Another thing that explained a lot of things to me is because I think almost every board meeting ad nauseum for the last year, I think I've asked about stroke. So with that in mind, I asked, can I go on a walkabout, please? So I did. So I went with, I can't remember who was with now, Lauren. Went with Lauren to Bridgen POW stroke ward just to see how things were going there. And I was worried, I didn't know what I'd see, but I was given a lot of reassurance actually by what I saw. Because when you look at the data sometimes, it's difficult to interpret what it actually means. And this 4-hour waiting thing, I just assumed there were loads of patients never ever being seen by stroke specialists and possibly coming to harm as a result of that. But that's not the case. It looks like that from the data, but that is not the case. I've got a long chat with the consultants as well, and they said they're going down and seeing the patients wherever they may be to treat them. They're not in a stroke ward, but they are being seen by specialists, and that gives me a lot of reassurance. So when you're looking at the data, sometimes you're thinking, "Oh, this is terrible," but they are actually being seen by somebody. Maybe not in the right place, and that's to do with the flow thing that Gethin was talking about earlier on again, and that's why it comes up then as a bad statistics because it's not in the right place. But yeah, a lot of reassurance I think from that walker. Thanks, Ian. Nicola.
Yeah, that reminds me of stroke as well. And I know we talk about stroke all the time. And it's pleasing to see, although the number's not huge, there has been an increasing percentage of those eligible that have been thrombolised. But my question is about the CNS model to optimise thrombectomy referrals. And it's a waiting decision for funding. Do we know when we might have an idea on that? If it's going to improve outcomes?
So it's part of the current planning within the IMTP, and it is part of the challenge at the moment is getting to that position, that agreed position, which will then enable us to recycle funds from savings into that CNS model. So it's absolutely priority. I'm hoping we will be able to progress that in the next few months, but it is about the delivery of the financial plan within the unscheduled care group. And we'll see where they've got to as part of the IMTP discussions. But at the moment, we don't have a pot of uncommitted money to do it. So it is about them delivering the efficiency within their overall budget, recognising they've had a £19 million investment this year.
Yeah, my question comes back to the boarding issue, and Carolyn saying it could become the norm. How does it work in respect of you've had to hold a patient, that patient is now discharged? Because I've been to a ward in this hospital this week where there was a bed in the bay window, no patients or anything, but it made me think, well, are they just leaving it there because they're going to have to use it again, or should there be a process where, I know moving beds and things are difficult, that it should be moved out so it's not there as an expectation to have to use it?
I think that's a really good point. Yeah. And I know we have, like today across our 3 sites, we probably have about 20 extra patients within a 6-bedded bay or a 4-bedded bay to support the flow. I think the challenge we normally have, I know it sounds ridiculous and it's something that we should be able to sort out, but you know, if the bed goes to bed store, to get the bed store out of the bed store and then onto a ward could be an hour, and we've got ambulances. So sounds like a bit of an excuse, but it's the reality. So from an efficiency perspective, it's quicker, but I think it's a really good point you made.
Can I just also, in terms of boarding, so Greg and I completely aligned on this. We don't want it. It's the wrong thing to be doing for what we work exceptionally hard to do is make sure that patients are not in those spaces for prolonged periods of time. The principle of boarding is around supporting outflow from the emergency department so that we can keep the emergency department safer and if necessary, be able to hand over an ambulance that's delayed. But the principle of it is that it shouldn't be a permanent bed and it shouldn't be a patient in there for a prolonged period of time. And I think Prince Charles, because they've had to board for a longer period of time, are very good at making sure that it's the patient that's going home the following day that is in that bed, so that we can and often we'll take the boarded beds down during the course of the day, and then potentially we'll use them overnight to just keep an element of that flow. And that's the principle, that it's there to be. You shouldn't be in a boarded bed for a period for anything over a number of hours. You certainly shouldn't be counting someone's length of stay in that bed in days. So that is the principle of how we use boarding. The pressures at times mean that we're not able to take them down as regular as we want. I'm pleased to say, the Royal Glamorgan today, we have got rid of ward boarding. So that's good. And that's where we want to try and get back into.
Thank you. Yeah, just very quickly, just to say massive thank you to Gethin for doing that data and the slides. And if we could have the slides, that would be great.
Yeah.
Thank you very much. I think it tells us, the story, doesn't it, around where we are. Just a couple of asks, I suppose. Could we keep an eye on that data and bring it back to board in 6 months, a year time or whatever, so we're sort of keeping that sort of monitoring going? And could we also make sure that we are including primary care staff in our discussions around secondary care and community hospitals as well? Because sometimes some of the feedback I've had from visits is that primary care staff would like to be more involved. So if, particularly on the ESTEC, which I always get wrong, the same day emergency care, and that sort of thing, because it might be housed in a hospital, or it could be somewhere else. So it's just those links between primary and secondary. Thank you very much.
And Linda Prosser?
2 years ago, the local authorities received a market stability reports which indicated that they were short of hundreds of care facility beds, mostly around dementia, and haven't been able to respond to that report. Haven't been able to. All of this is a consequence of that, and in many ways brings us back to the earlier conversation we had about our work with the local authorities, their accountability, and how far we might push that section 33 to jointly work together to increase capacity.
Thanks, Linda. And Max will refer that as a possible work. Thank you. Any other questions or comments on this item? No? Okay, colleagues, we'll note the report. Thank you very much. Moving on to item 6.2, the part 2 of the dashboard, which is the financial performance. I'll hand this slide. Thank you, Simon.
I'll try and keep this one as brief as possible. Head into the year end, and Dom's going to try and done it.
Sherry goes.
Yeah, he's going to go for one. So in terms of the revenue position, it's looking on track to level break even by the year end. This report says there's a potential for an upside. I think looking at some of the things I've seen rolling through in the last couple of weeks, that probably lands on the nose. Which is about as good as we get. In terms of our underlying deficit, that was adjusted in the previous month to reflect the receipt of the conditionally recurrent monies, which we assumed based on a confidence in delivering the position, which means our underlying deficit is 19.4 million. That then feeds into our overall planning for 24-25. Not sure which year we're in as we sit here today. It all gets very confusing. So our savings again are largely sitting, well, they're actually in ahead of the full year savings. Again, we'll look at the recurrent forecasting, which is 28 million, which is over our initial target. So that's positive. Cash, slightly higher than we were expecting, but that's just because we've had some late receipts of monies and we're expecting that to be managed to the year end. Capital, those of you who've looked at the graph towards the end of the report will see that there's a sort of steep climb in the last couple of months. That isn't because we haven't planned this properly, because we've had a sort of 13% overcommitment to allow us to land, but does reflect the fact that we've seen significant additional capital released from Welsh Government colleagues over February and March, which we are running to make sure we've spent effectively, largely in the digital space, but some other areas as well. That is both NHS capital that's been recycled, but also wider Welsh Government underspends. And Stuart's team has been spending particularly effectively the last 2 months on a lot of things, some of which will then provide us with benefits coming into the next financial year. So that was all I was really going to highlight on that.
Thank you, Sally. Any questions or comments on Sally's report? As we're almost at, yes, sorry, Catherine, over you before I finish up.
Just to say well done, I think, to everybody and all the team around, fingers crossed where we're landing, because it's a massive challenge. I totally agree. I think in future it would be useful to have a bit more of a breakdown on the capital spend.
Yeah.
You know, in terms of, because there's some significant projects.
We tend to do a 6-monthly detailed capital report that supplements this. So we'll do that for next month, really, to give the year end position.
Yeah.
Thanks, Sally. Just to echo this point, so Sally, I certainly appreciate when I look back to April last year, the robustness and the rigour that was put into the financial planning in this health board, with a bit of variation. I know that the Welsh Government obviously provided additional resource cover to health boards. However, we were very much on target. I think we had high levels of confidence in the work that you and your team and the exec team have done alongside our care groups to identify where savings can be delivered, ensuring that we were attempting to stick to the plan that was set out a year ago to government. And I just want to thank you and congratulate the team for the enormity of the effort, and also to say thank you for the work that's been put into the next item, which is around the IMTP and our budget for 2024-25, to bring us into that balanced position for heading towards the end of this financial year, putting us in a more advantageous position potentially, although still challenging and difficult, going into the next financial year, is by no means a straightforward process. So thank you and the team for what you've done. Really, really appreciate it.
And it is a complete organisational effort to get here, and this is not easy because we recognise that there are lots and lots of pressures, but holding this and managing it into future financial years will give us a better position as we try and plan and think about how we reshape our investment in future.
Excellent. Okay, the board notes the report. Move to item 7.1, which is the IMTP and the budget for 2024-25. This matter is in front of us for approval ahead of a submission to Welsh Government by tomorrow.
Today.
Today. It's 28th of October. Well,
Not doing it tomorrow.
Well, I think the deadline was tomorrow, but yes, except for the fact that tomorrow is a bank holiday, of course.
Could you go to slide 3, please? Because we've just covered the first 2. And I think, so let's go on to slide 4, which is a reminder of what this plan has to deliver. All of these inputs, everybody's guidance and requirements satisfied as far as we can. The next slide just reminds us of the timetable. We'll start back before Christmas with care groups and have been working through various committees and activities to sort of narrow down and prioritise the things that we can do whilst meeting our overriding target to break even. So I'll pass over to Sally to do. So if you can go on to slide 7 to take us through the finance slides, and then we'll talk a little bit about what it means for services.
Sally, thank you.
Thank you. So, as you know, when we last discussed this, we had a board development session and a conversation through PPF as well around what our ambition was, which was to submit a balanced plan. We recognised that further work was needed to improve the risk positions with increased savings and reducing cost pressures, investments and risks. So the net risk at that point, unmitigated, was 19 million. And we agreed that in terms of confidence in a plan, we were looking to reduce that to below 10 million in order to allow us to submit a plan, knowing that there's some significant risk within that, but that's the sort of level that we would feel comfortable managing. So the final cut plans from care groups were submitted on the 20th, and then we've had some further discussions. And I think it's fair to say, Gethin, the original resubmissions were less positive than you'd hoped, and therefore there was another resubmission on Tuesday. Those were Tuesday, and we've been working that through for the last couple of days. So all of this has been moving around at the margins. The substance stays pretty much the same, but it has been moving. We can just drop down there. Next slide. Right. So this is just to remind you where we get to with the final cut plans. So it shows you the sort of deterioration in the adjusted position between month 10 and 11, which effectively is the thing I was just talking about in terms of the report here. We've been seeing some costs hitting in the last couple of months, which then moves into people's recurrent position. Then we had recurrent cost pressures, not in the draft plan. That's now been reduced right down. We've got the, or that in terms of the balance, we've got new non-recurrent cost pressures at fairly marginal, a savings target, which sits at the, I have to put my glasses on, which things are bad if I have to put my glasses on, because I do not wear them, down to the 26.189, and then savings plans currently sitting at the 22,990. So we've got that sort of forecast deficit position there, excluded in terms of the final plans, which sat us at 6 million, but I'll tell it, or 8 million, 6 million. I'll talk to you about how we deal with that now in the next slide. This is really difficult to see. So if we look at the delegated totals and saving plans, this is just to remind you here about why we've got, how the different stages that we've got to. So in this, you can see that stage 4, which is pretty much firm plans, we've got 8.9 million. At stage 3, we've got 7.5 million. Stage 2, which is more sort of going into the ideas phase, 5.4, and 1 million in stage 1. So 22.9 in total savings, but there are risks around those sort of stage 1 and stage 2 in particular as we move into the sort of full year. We go to the next slide. This one is really going to challenge me, isn't it? So if we're looking at this, we can see here, there's the plan at the 4th of March, then the plan at the 20th of March, and then the plan at the 26th of March. So our plan was to break even. We've looked through the risks. So outstanding allocations. Oh, brilliant. You found it. And now I can take these. My computer's refusing to move. So you can see here that we've got the recurrent allocations here of 2.6 that we're still waiting for. So that's the balance of the pay awards for 23-24. It is quite strange that we still haven't got all that confirmed, but that is the position at this point, so it's still a risk. The final cut plans, which we just talked about, the forecast deficits, which have reduced down to 6 million, They were at 11.3 on the 4th, 10.1 on the 20th, which is why Gethin wasn't so happy, and they have now reduced down to 6 million. In terms of delivery risk on forecast savings, we have just included in this version a notional 10%. It is very notional. It could be larger, it could be smaller. I think it's important it's there, because I think when we get our plan reviewed by Welsh Government, they will expect to see it. Then we've tried to look at the second cut plans in terms of potential risks that they've identified in their plans, mainly in the care groups, around the high risks, the medium risks and the low risks. In terms of what we're including within our sort of net risk position, we've got 100% of anything high risk, 50% of anything medium risk, and low risk we've decided is 0. Now you can debate all those points, but that's where we sat it. The risks did grow between the 20th and the 26th, but I think that probably reflects some of that movement between those things that people are identifying in their underlying position and what they're now seeing as risks. In terms of further industrial action, you see that says to be confirmed. At this point, I'm not proposing we include a number in our risk assessment. The reason for that is we can't estimate it with any degree of reliability. I have had a conversation with Welsh Government colleagues about that approach, and they accept that we can't make that judgment, but it is a significant risk, as we know, to the plan in terms of what happens. And we've also got there's potential deterioration in month 12, but I'm hoping we don't see any further movement on that. So in terms of our investment choices, we have we were able to identify next slide. I'm going down on my own now. So in terms of the investment choices, we may need to move some of these around and work them through in the day. There's no actual business cases against these. They are fairly marginal, remembering we've already got another million identified within the original plan. So there's digital proposals, the LIMS that we've previously approved the business case with, there's a need for staffing support to get that implemented properly. Some work around WOD and learning development, something around the clinical services strategy. And again, there's a little bit held within Linda's budget as well for that, but we will need to work and understand what we need to do around that. And again, that may need to be flexed during the year. And then we've assumed around the internationally educated recruitment and around patient-centred contact that we will be able to access some of the 2 lots of 5 million that are being held by Welsh Government for initiatives in that sort of line. In terms of that, we've got a sort of funding bid for internationally educated recruitment around 1.9. And I think for patient-centred contact, we're highlighting a bid around 1.2 in next financial year, rising to 1.4 in the following financial year to be an exemplar to deliver the benefit. We need to make sure we've got the right cases for that and we understand the processes, but we want to strongly signal that here. And as the only health board that will be, I think, submitting a break-even plan, we would hope that we would be prioritised in terms of receiving those additional funds so that we can continue to drive the change and deliver a better position. So the contingency there has now been applied to those investment choices above. We are identifying some potential for further balance sheet opportunities, which we think is low risk, and then some opportunity around some retrospective VAT recoveries around the Microsoft licenses, which is a medium risk, but we are hoping to see that through. The other one that we're still just trying to work through because it's very, very complicated is there any potential improvement in the energy costs? We've received an envelope. We are still working through and trying to understand what next year looks like. We've moved into a different basket with our sort of procurement arrangements. which is a slightly longer term one. They have bought most of the energy now. It's about understanding the bits that aren't about energy, which are called non-commodity prices, that seems to be causing a bit of delay. So that takes our net risk, which is unmitigated at this point, to 9.4. We do need everybody to sort of appreciate that means at this point we could be up to 9.4 million off our break-even plan, but that we would some of those risks may not materialise, others may be able to be mitigated down to give us a better position through the year. I think what's really important is the work that we've done with the care groups, and Gethin has spent a huge amount of time working through their plans and looking to how the improvements can be delivered, because we are investing a really significant amount in our frontline services at approximately sort of 44 million. As Gethin said, in unscheduled care alone, that's 19 million. And the opportunity now is for the care groups to stop having to stand up services on a temporary basis. There will always be some flex and some temporary, but to look at permanent staffing models that would be better for patients and better for our financial position. So trying to find a bit of a sweet spot around that. So the recommendation, drop down a slide, after the discussion that we had at ELG on Monday, is to submit a balanced financial plan noting the risks. The investment choices are prioritised, and the net risk in the plan reduced from 19 million to 9.4, and further updates are being supplied by care groups, which is reducing some of that down again. So we are going to need to do urgent work to make sure our planned savings programme can be delivered, to develop those plans that are at stage 1 and 2, so that they are genuine plans rather than planning assumptions, because that's what we're asked to do by Welsh Government as they work through the monitoring returns. And then the important thing for us to note, a slight air of hope, is we've submitted an indicative 3-year plan. So firm year 1, indicative years 2 and 3. We've made some assumptions around that, but we think those are reasonable assumptions. We'll see if Welsh Government share that view, but that will provide us with opportunities in years 2 and 3 for lower savings targets and some discretionary investment. So sort of a slight, a sort of smear of jam tomorrow.
Good way of ending presentation.
Yeah, keep going.
Yeah.
Can you give me the next slide, please? And again, thank you. So we actually wasn't going to dwell on this one. This was just about a reminder of how we've worked with the care group to build a plan. So let's go on to the next one. And again. Oh, and again, got some animation. I want the next slide, really. Thank you. So the next section of this, and Gethin, I don't know if you can sort of whiz us through it, takes us through each care group, a quick oversight of the requirements that are there. But in red on the right hand side is the ones where we've got some expectations that come through a bit late, that there is a risk of delivery, because it was only within the last month that we had some of these targets come through. So you've got a slide on the expectations, and then the next slide, which is a reminder of the plan on the page for each one.
By all means. So in terms of planned care, as you'll see, so we've got sorry, can you go back up a sec? Sorry, thanks, Kath. So in terms of the performance requirements for planned care cancer, there is a national target of achieving 80% by March 2026. Our submission this year is as part of our route map, is to get to 70% by March 2025 as part of our improvements. And I think our cancer as that is deliverable. We are moving towards a zero cohort of patients waiting more than 52 weeks for their first outpatient, and moving down to a zero tolerance of any patient waiting more than 104 weeks for referral to treatment. We are estimating we will finish the year with circa 2,000 patients waiting that time. The main risk area in planned care is to achieve a 52-week maximum RTT, which is going to be a real challenge. And more work needs to be done to understand where we think we can get to by June. Again, follow up patients again moving forward. So if you go to the next slide, please, Kath.
These have been seen and discussed by the board before.
So I don't.
There aren't any changes.
So don't intend to talk through these, but you'll see particularly for planned care it is around GIRFT and that approach, and that I think is what I propose to bring back to May board is a real focus on our productivity improvement work, which we're doing in conjunction with ICTM, and the adoption of all of that GIRFT process across all our planned care specialties. So I don't intend to dwell. So next slide, Kath. So for urgent and emergency care, it is around red calls being at 65%, which for CTM, as you'll be aware, is a significant challenge. We're looking to a 12-month reduction trend on our median response for ambers, 15 minutes or less for triage, and a 60-minute time from decision from arrival to decision maker, and clearly an improvement trajectory as we already have in place as part of our TI work for 95% to be seen. Interestingly, in England, you might have seen that they are now the planning guidance for 24-25, which was issued yesterday. It is, and it's normally Christmas Eve, so it's very late. So England are aiming for 78% compliance with 4 hours, and then again looking to reduce the number of our 12-hour waits within our emergency departments, as we've discussed today. So again, happy to move on. Next slide, please. And again, a big focus on unscheduled care is some of the specialty work, particularly in cardiology and respiratory medicine, but also working through the detail on our emergency care approach. Next slide, please, Kath. Diagnostics. So the one thing I was just going to draw out here, which I didn't draw out on the performance report, is they are with removing weight management from the criteria for dietetic waiting times. So we will not be reporting dietetic weights, weight management referral weights in the dietetic cohort. They will be excluded and reported informally. So that was something that came out yesterday. So again, most of these, and I would just draw out that many of you know that we had about 10,000 patients waiting over 8 weeks for an ultrasound at the beginning of this year, and 13,000 waiting for an ultrasound over 8 weeks. That number is down to 404 over 8 weeks at the end of this month. So huge effort by team radiology in delivering that. So we are, I think we're clear. We've got a number of actions in train to deliver those for the D&T specialties. Next slide, please. Probably just work through these, Kath. If you go to the next performance slide, please. You've got all the
slide 25 we need.
So then if we look here, back one, thank you. Lovely. So again, we still don't have the target for dental services, but I'm sure that will be forthcoming. And again, many of these targets for primary care are ones that we're already achieving. So we remain content with these on that score. Next slide, please. And then again. And then for mental health, again, as many of you have seen these, the main risk target here for us next year, but is part of our TI work, is 80% of patients being seen within psychological therapies. We are now achieving the 80% marker in or have plans to achieve them in all the other areas. So the main risk target for us and focus is on psychological therapy. Lovely.
Last one.
And again, they're all parts of the work that we're doing. What the ADHD target will equally be a challenge, but I understand that Welsh governments are looking at their approach to monitoring that. So yeah.
Thank you. So the next slide is the people one, so it's down to, and I think it's just worth noting, as Sally said, one of the recruitment initiatives is the internationally educated nurses, which we are in our plan, we're dependent on getting more than our fair share of the national pot. We've asked for 1.9, the fair share is 0.7, and there were noises yesterday that indicated that 0.7 might be the number. So there's a significant risk around that we should note. Helen, we've seen all these before. I don't think anything's changed. It is in the written plan.
Yeah, that's fine. And I think, the people chapter covers two parts. It's the people priorities, which really link to our CTM 2030 priorities. And the second part then is around the actual workforce plan, looking at our workforce demographics to understand, what some of our challenges and opportunities are and what the mitigating actions are that we need to take. I think that slide and the next two slides really demonstrate kind of the actions, some of our key priority areas, and then our workforce planning approach to work forward through this next 12 months. I think one thing that we've done this year, and just to make note of, is that we're very much using some of the census data that's available to us to really help us to understand what some of our future workforce challenges are going to be. We've never done that before, but it's proving really helpful, especially when we think about the population that we're serving here and some of the education levels and age profile and what that's going to mean for our workforce. So that's contained in the plan, and it's something new this year that really informs, I guess, some of the actions and priorities moving forward.
Thanks, Ellen. And then just two slides on digital, if you could go to 33. Yeah, thank you.
Okay, and just Sally's actually covered it in terms of the financial piece. I suppose the one thing that is reassuring for the board, we are able to cover some of our essential clinical need in terms of our digital patient notes and the way in which we connect with some of our core systems. So that is in the plan. And obviously one thing in the narrative which we've tried to build out is our opportunity actually to be an exemplar around the patient contact piece. So we really made sure that is at the forefront of the narrative for digital data going forward.
Very quickly on that, Stu, at the board development session, we were told that our critical care units, which had one system covering RGH and PCH, obviously with another system, database covering POW. Does this allow us to invest?
It doesn't within our current bit. That's the bit we've got to now work through with Gary. Sorry, Gary. Yeah, got to work through it again, but it doesn't within that.
Because that was presented to us as being quite critical before we could even make any features, any early decisions around the shape of our critical care service. So I think that was
no good, but
yeah. Okay. All right. Okay.
And so the last slide, please. So I know that you've had a lot of paperwork around the IMTP. You've had the 110, whatever it is, page submission, and this and various annexes that have come out during the week. And appreciate that's a lot to get through. There's just a list here of things that have changed since you received that version that will be going into the final version. It includes some bit more detail about our sort of flagship patient-centered contact redesign project, which, as Sally said, we're hoping that will be centrally funded. There's more about the type 1 diabetes project, which is quite an exciting service redesign. which will be is in the final version that you haven't seen. The 6 goal stuff has been developed to a much more granular level, along with the further faster, which is a new fund that we need to really make the most of. And we have yesterday we got in the cluster plans from the localities, and those are available on to you to have a look at. We haven't included them in the board pack; they just came in too late. And the other update, which Carolyn's just reminded me of, that has now been made to the final document, is that the WISC ICP integrated something plan. What's the C stand for?
Commissioning.
Thank you. As was agreed last week, so that we've now that's now clear, and it is in our financial plans. So there's a few updates there, which you know, I think we've brought everything together now that's happened this week. And you know, as you can see from the investment profile, it is very limited, and you know that in order to make any more investments, we have to make more savings, and that's the reality of it. So as Sally said, we'll be working through that more as the year goes on, because we're very conscious that there are some high priority areas that we need to stretch for, that we're not able to fully account for just now.
Thank you, Linda, and thanks to Sally and to get in, and to Stu as well for talking us through the key aspects of the IMTP. Question from Patsy.
Yeah, thanks. Really comprehensive. I note the stroke investment has come out, and I understand the risk level needed to be less than where it is. But is there any national money for stroke likely to be available following the National Review of Stroke Services?
Not that we're aware of, Patsy. I think, as Gethin said earlier, in terms of the unscheduled care group, they now have a 19 million addition, and part of Gethin's challenge to them as the care group is to carve out sufficient funds to prioritise stroke within that, but that's needs further work through.
Okay, thank you.
Thanks, Patsy. Kath.
Yeah, just I mean, 3 points. So I mean, this is my first IMTP. I think it's a massive amount of work and fantastic. So well done to everybody. 3 things I just wanted to just note. One was around mental health and the risk we're still carrying around our systems and data. The other one was around the people side and the embedding of the care groups, understanding that the care groups are still quite new and we're still moving people around and going through the OCP process. And the third thing was an ask around years 2 and 3 finances. Could we have a session sometime in the next 6 months to think about how we try and turn the tankard around to support primary care and prevention and early intervention around our finances for years 2 and 3, once we've got out of looking at the budget? And you know, I know you'll be going through audit now of this year and everything else, but could we try and carve out a little bit of space to start thinking about sort of future years?
Yes.
Thank you. I mean, just following on from that, I think John and I was having a side conversation about the level of investment is really low. Going back to the early conversation we had about clinical pathways and pressures, think about ballpark cost of £500 a night to keep a patient in a bed.
Yeah, exactly.
200 people who don't need to be in a bed. That's £100,000 a day that we're spending on looking after people in hospital who could be being cared for in a community setting. So I'm afraid to say it all comes back to the same challenge of £700,000 a week being spent on looking after people who don't need to be in beds. And that's our money that we're not now able to invest in stroke, in improvements in primary and community services, in digital, in all these other things we want to invest in, because we're pouring money into the wrong bit of the system. So, you know, in some ways it's a neat correlation of all the clinical and operational pressures of we've talked about in this issue. The financial impact of that is this, and you know, we are trying to do our bit and hold our line and deliver a balanced position because it's the right thing to do, because it means we will be in the best place moving forward. But I think, as you all see, we're all as equally frustrated that we can't put the money into the things that we really want to be able to invest in. And I think, you know, we've got a real imperative to sort this challenge out of using that money in a better way, to try and improve the care for our patients, but also to enable us to be able to have some resources to invest in other things that we'd like to invest in.
Absolutely. Sally, and then Stu.
Yeah, so alongside some of that, it's just worth reflecting back on Gethin's presentation around unscheduled care as well, which is our numbers presenting have actually gone down. And that's been reflected in an income loss at PCH alone of over 6 million.
Yeah.
So we've lost funding, but we're actually have people staying for longer and we're seeing more pressure in the hospital. So there is also something about our system and how we count and manage things that is sort of counterintuitive, because we're not recovering costs in the same way where we put in alternatives and zero lengths of stay. So there's a lot of work to be done about how the system works as well, which might help us manage some of that.
Thank you, Sally.
Thanks, Chair. And just and that's absolutely right to mention the mental health system and data provision. And just to assure you all, I suppose, in that it's not that we're not doing anything in that space, and we are aware that there are some monies potentially available within Welsh Government next year, and I've made sure we're at sort of front of the queue in terms of a call on that, but just clarifying what the process will be in terms of business case or access to that money. So we'll be working in collaboration with Bev and certainly in that space.
Thank you. Thank you. Well, can I ask the board to approve the IMTP and the budget that's been set out this afternoon for submission to Welsh Government later on? Yep. Thank you all very much. Moving on to item 7.2, the acute clinical services plan update. Linda.
So just very briefly, I won't talk to the items in here, I'll take any questions. I've made a commitment to keep you updated, on the activities around the acute clinical services plan, the fact that we've been, really crystallising the baseline analysis of our services and working with care groups around what their services could look like, including starting to map out what it takes to fully evaluate proposed changes, because our intention is still, we're working with the Consultation Institute next month. Our intention is still to do some form of consultation later in the year, possibly on a limited number of changes, but to include a sort of overarching set of principles and vision. So we are on track for that. Although it's one of those things where the closer you get to it, the more work you realise there is to do to get to that position. And I know that both the Chair and Chief Exec are not prepared to take anything to the public domain that hasn't been fully worked through quite rightly. So our commitment is to stick to that, but to be really clear about any where we make sure that we're robust in what we're offering.
Thank you, Linda. Thank you for the report. Any questions or observations? Happy to note the report. Thank you very much. Item 8, the consent agenda. Can I ask the board to approve those matters for approval? Item 8.1.1 to 8.1.3. Yes, happy to approve. Thank you. And those items for noting, 8.2.1 all the way down to 8.2.5. Happy to note those. Thank you very much. No other items of business that I've been made aware of. Under 9.2, if I can ask for any comments within 2 weeks of this meeting as to how this meeting has gone today and how we have performed our duties as a board, I'd be very grateful for that. Nothing to report under item 10. And on item 11, just to confirm that there will be an extraordinary public board meeting via Teams scheduled for 9 AM on Tuesday, the 9th of April, where we will receive a report on the emergency medical retrieval transfer service. The next scheduled board meeting, however, beyond that will be the next public meeting is on the 30th of May, commencing at 10 AM. And just for clarification, all future public board meetings will be here at the hub, because it avoids us having to find venues where we have adequate and high quality sound that can be picked up around the room. So we did look at Keir Hardie Health Park. We struggled to be confident in the technology there to ensure that what people were saying in the room could be adequately broadcast. So I've decided future public board meetings will be here. but board development sessions will be elsewhere because they're not in public. It's just us. So I think that would make life a bit more straightforward. Rydw i'n dod y cyfarfod y bod iechyd ben, a hofyn y diolch y fawr sydd wedi ymuno yn ei gwylio cyfarfod heddiw, and I'll bring the board meeting to a close. Would like to extend my thanks to all those who participated in the meeting or who have observed our proceedings today online. And finally, can I wish everybody a very happy Easter? Thank you very much.
Thank you.